Morning, everybody. Thank you. It's the third day of this conference. Listen, I was chatting to the presenters because this has to be a fantastic experience for everybody and from the presenters. And I think all of you are going to present for the first time in a conference. They are students, postgrad. So this has to be as we do things in IFEC, like very relaxed, and we're here to learn. And we are a movement for change, so we want happy people to be pushing. I'm not the chair that appears in the app, because I'm more interested in evaluation. So my name is Arturo Alvarez. I am the head of solutions, which is the IFEC service that, or the part of IFEC that supports organizations in evaluating integrated care programs and services. So I was more interested in this session in particular than the one they allocated me initially. So we've swapped. That's why my name doesn't appear. But if you go to 12B, you'll find my name there. And but Bennett is one of our senior associates. He's very kind. And he said, yeah, no worries, let's change. So that's why I'm here. This session is evaluating health systems, and we've got three presenters. The way I like doing this, and this is what I've suggested to them, and they say, yes, they are going to have 20 minutes. And in their 20 minutes, they can do whatever. If they want to get from their presentations like engagement with you, then they have to stick to 10 minutes, and then leave time for questions. If they want to just present what they are doing, then you consume the 20 minutes, no time for questions. That's how I like doing this. So, and I've already taken 5 minutes, so I'm going to share that between you guys. So thank you very much for being here. If by any chance you want to come closer to show your support to the presenters, and then I'm going to give the floor to Rini Bhatnagar. Yeah, and you introduce yourself, and you've got more information on the bio in the app. So thank you very much. Rini, whenever you want to start. Thank you so much. You've got the slides there? Yes. Yeah.
Hi, good morning, everyone. So my name is Rini Bhatnagar, and I'm working as the postdoctoral research fellow at University College Dublin. And today I'm going to present my research project, that is the iCare Wounds study, which says intelligence and integration of care for smarter chronic wounds management. So starting with the introduction, iCare Wounds is a European Commission-funded project under the EU Horizon Research and Innovation Program. The main aim of this project is to develop and validate a patient-centric digital platform for chronic wounds based on the trustworthy artificial intelligence technologies, and how this platform will be helpful. So this platform will enable the clinicians to capture the wound images, extract the different features of the wounds, and it will also support them in decision-making for tailored patient care, and it will ensure data interoperability via healthcare standards. So the project currently is in its initial prototype development phase, which will be tested in a usability and a feasibility study. So the study is taking place in 3 countries. So there are 3 pilot sites: Ireland, Spain, and Poland. Now moving to the methodology. So in this study, we are using the co-design method, where the expertise of the knowledge partners was combined with the needs of the patients to develop the iCare Wounds patient-centric integrated care model and a care pathway, which will guide the digital platform. So as a part of co-design method, we conducted 2 workshops, the stakeholder mapping workshop and the co-design workshop. And these workshops aimed at obtaining multiple expert viewpoints, facilitating iterative feedback, and fostering a shared understanding of the needs and challenges essential for development of the integrated care model. And we also used the Sirocco questionnaire, and it was used to capture stakeholders' perceptions and experience in designing and delivering an integrated care. So I'll provide some information about the Sirocco questionnaire. It is an online self-assessment tool to assess the local readiness, needs, and priorities for adoption and scaling up of the integrated care. It is a well-validated and tested questionnaire, which is tested in over 72 regions and organizations, and it is available in 9 languages. So more about the Sirocco questionnaire. It is, again, it has 12 critical dimensions, and all the critical dimensions are shown here. So when we fill the questionnaire, so each dimension, it begins with a brief description about it, followed by a 6-point response scale ranging from 0 to 5. So 0 means not fulfilled or not present or available, and 5 means representing fully fulfilled or totally present or available. And the online, as I've told you earlier as well, this tool has demonstrated strong content validity and reliability and has been validated prior in various countries through several studies. So for the filling of the Sirocco questionnaire, diverse group of stakeholders from the 3 countries were invited to fill the survey. And the stakeholders were then grouped into 5 categories, which included healthcare providers, healthcare organizations, patient organization, patients and caregivers, clinical scientists and researchers, and policy makers. So this slide shows the results, some results from the Sirocco questionnaire. So this is the spider diagram for the maturity model, which is comparing 3 countries. So in this spider, if you see Spain, which is in green color, it is presenting higher ratings in majority of the dimensions as compared to Ireland and Poland. And in the blue color, it shows Poland, which present a moderate rate for all the dimensions. And now I'll compare some more results based on dimensions between 3 countries. So starting with dimension 1, which is readiness to change. So Ireland showed high readiness to change due to initiatives such as launcher care, which creates political and public support. Spain showed moderate readiness to change with commitment from healthcare professionals, but limited public engagement. And Poland showed low readiness to change with limited political will and public awareness. Now moving to dimension 3, which is the digital infrastructure. So in Ireland, digital infrastructure is still a bit underdeveloped, which lacks standardization and integration across levels of care. In Spain, the results showed that foundational electronic health record system is present. There are some regional successes, but there is no full national integration. And in Poland, the digital infrastructure is still in foundational or preliminary stage, with some isolated pilot programs with limited reach and no national digital strategy, actually. And for dimension 8, so Ireland is beginning to focus on citizen empowerment with a growing emphasis on PPI, but this is still largely at a very high level, primarily focusing on modernized pathways. In Spain, there is recognition of the importance of involving citizens in their own health management, specifically through tools like different monitoring apps. Healthcare professionals stresses the need for more research and proactive citizens who can take charge of their own care. However, healthcare professionals acknowledge the need for stronger structures that facilitate citizen participation in the health system. And in Poland, the role of patients in decision-making is often ignored. And many respondents also said that patients in Poland do not have meaningful say in their healthcare decisions. And lastly, dimension 11. So in Ireland, the innovation level is nascent, with innovation primarily driven by some individuals. And the key challenges observed in Ireland is limited dissemination of successful practices, resource constraints, and limited institutional support sometimes. In Spain, the innovation level is moderate, with some innovation present, but it's fragmented. So the key challenges observed there was limited system-wide integration, need for stronger innovation management, and coordinated frameworks. And in Poland, the innovation level is very low, with some isolated innovation efforts. So the key challenges were lack of awareness and cohesive national innovation strategy, limited resources, and engagement at systemic level. So from here, I am going to now present the integrated care pathway for spinal cord injury patients with pressure injury in Ireland. So in Ireland, the target population for eye care wounds project is the spinal cord injury patients with pressure injury. So firstly, I'm going to present the care pathway which is currently followed in the hospitals. And after this, I'm going to explain the eye care wounds integrated care pathway, where I'll be explaining how technology will be introduced in this pathway. So firstly, when a patient comes to the hospital, the first step is comprehensive patient assessment, where the history taking takes place, pressure ulcer risk assessment takes place using any of the validated tools such as Waterloo score in Ireland, in the NRH, and then a complete skin assessment takes place. So now if the pressure injury is present in the patient, the second step or the second stage is wound assessment, where the clinician does a measurement of the wound, determines the stage of the wound, different types of tissues in the wound, level of exudates, and then the photograph of the wound is taken. Now, once the wound assessment is completed, the third step is wound evaluation and management. So here I have provided the management stage-wise. So stage 1 and suspected deep pressure shear induced tissue damage, they are obviously serious ones, but they are usually not open wounds. So here, the treatment will be pressure offloading of the affected area, skin care, suggestions about skin care, nutrition, and hydration. And for stages 2, 3, 4, where the open wounds could be present and they are more advanced stages, so different choice of dressings based on the condition of the wounds are suggested, nutrition guidance, and onward referral to specialist services if required. Now, once the management has been started, the next step is really important, which is ongoing wound care, where tracking of the wound takes place every 7 to 14 days. And in Ireland, in NRH, we do an image-based tracking, where usually the photograph of the wound is taken in every 14 days. And based on the condition or the progress of the wound, suggestion to the referral is given to the appropriate specialist services. Now, I will start with the eye care wounds integrated care pathway, where I will be explaining how the technology will take place. So now, when this will be implemented, now when the patient comes in, the doctor will have a tablet the doctor or the clinician will have a tablet in their hand, and they will take the image of the wound. Okay, so now at the first step, there will be, as the during the comprehensive assessment, after history taking, pressure ulcer risk assessment, and skin assessment, the technology will provide preventive care suggestions. For example, suggestion about skin care, such as we have skin bundle in Ireland, suggestions about nutrition, hydration, etc. Now the second step is the wound assessment. So once the photograph is taken by the clinician, what the technology will do? The technology will detect the wound, that is, it will create a box around the wound which contains the wound. So it will just create a dead territory around the wound. The wound territory, I would say. After that, it will classify the different tissues present in the wound, for example, necrotic, sloughy, granulation, and the percentage of those tissues. And after that, it will segment these tissues. That is, for example, there is a necrotic tissue, 20%. So it will draw a region around, in the image, around the necrotic tissue, and then maybe around sloughy tissue. And at this stage of the project, staging would be conducted by the clinician. Now, at the third stage, that is wound evaluation and management. So for stage 1 and suspected deep pressure tissue injury, which are less severe ones and not the open wounds, technology will provide suggestions regarding healthcare habits. For example, it will provide suggestion to the nurses for repositioning of the patients, because nurses are usually busy and they sometimes forget to reposition the patients. So it may provide some alarm to the nurses for repositioning. And for stages 2, 3, and 4, which are the bit more advanced one, technology will provide, the most important thing is digital prescription, that is choice of the dressing to the clinician based on the condition of the wound. It will also provide suggestion for referral to specialist services if it is required, and also specific recommendations for specific patient cases. And I would say this is the most important step, because progress tracking is really important. So for the progress tracking, which takes place in every 7 to 14 days, technology will really fasten the process, and it will really help in reassessment through imaging. So finally, how this digital platform will be beneficial for the clinicians and how it will empower them. So it will lead to standardization of the care of the chronic wounds. It will also lead to improved quality and safety of care for the patients, and it will also improve the efficiency and enhance decision-making for the clinical teams. So thank you so much for listening today, and I would like to thank our European partners, our funders, and the ICIC Wounds team in Ireland. Thank you so much. No, I have this one.
I enjoyed, I'm a health economist. I'm conducted a similar study in Hungary to measure the cost effectiveness of this process that you presented. It's a very nice presentation. My question is about the integration, integrated care. What is the integrated part, integrated approach in this process? So that you presented is mostly focusing on the healthcare, simple healthcare issues.
So the current platform which we are developing is for the healthcare partners, but in this study we may also develop a similar platform for the patients as well, where patients will also be, it can be used as an app as well, and they can use that app at their home as well. So they'll take a picture of their wound, and they may get some information about it. And it is still in progress, it may come, but it would really be helpful for them because, it's very unsafe as of now, taking a picture and searching it on Google. So we may have an application for patients as well. And this platform is for the healthcare professionals at the moment.
Fantastic. Any other question? Questions? I've got questions. I think it's very nice how you identify what the technology adds to the existing care pathway, with acre wounds adding to that. But I was sort of thinking, are you also aware of the challenges that have you come across the challenges that also technology adds to that? So have you come across any particular challenges in using the technology and applying the technology to the existing care pathways? Any resistance that you have come across?
We currently have another project with us, the Rosia project, which is looking at the rehabilitation services. So at the moment, I would say we are I understand there are challenges with the technology, but I would say the way we are developing it, we are working in collaboration with the clinical teams so that the platform which is developed is providing accurate information rather than, it is providing inaccurate and then changing it. So I would say we are trying to, lessen the challenges which may come across. And for a technology like this, I would say the most important challenge would be correctness of the information provided by this platform, because it will, although clinicians will at the end of the day, they will have their own say, but still the platform will be able to, guide them in a way. So that's why, and in Ireland, for example, we are majorly focusing on nurses because with the collaboration, I have understood that nurses would be the best people to use this, would be the most important people to use this platform in Ireland. So I would say that correctness of the information on this platform can be the most important challenge as well. But at the moment, we are trying to reduce as much as we can.
Very good. We've got 3 minutes, so come on. Questions? Yes, please. If you want to introduce yourself and say very quickly.
Yeah, just remaining to my question, you mentioned the patient at home, but might be another platform patient or elderly people who live in residential homes. Is there in your plan to open this platform for social care, long-term care facilities?
Based on the success, because this is the first phase of the study, so based on the success of this one, it would be really, and thank you so much for your suggestion as well, because this can be a very good idea to introduce it to the patients who are in the residentials, because pressure injury could be a very important, condition happening in residentials as well.
Is it an opportunity to join to this project, or have you finished?
No, we just started last year, so we have just completed 1 year, and we would be really grateful to talk to you and, to collaborate.
It's okay. Since years, we have been collecting and analyzing huge data in Hungary, in healthcare system. The public hospitals, almost all the public hospitals enjoyed to this program in my country.
Yeah, okay.
I will turn to you.
Yeah.
Fantastic. 1 minute. Can I ask for a very quick question? It's like, I'm a bit curious about why did you conduct the Sirocco, and what the Sirocco brought exactly to the design or the reformulation for each country of
we filled the Sirocco to understand the maturity level and understanding of the different, people from different domains about integrated care. And from the results of the Sirocco questionnaire and also from the results of the 2 workshops which we conducted, we were able to understand the exact needs of the...
So it's the context and the needs, and okay.
Yes, exactly. And it was really helpful because Sirocco questionnaire, the results, and you can write, comments as well. So there were really detailed comments, and from that we were able to understand a lot about all the 3 countries.
Fantastic. Yes. Yeah, we've got 30 seconds, Sonia. Very interesting, the results between Spain,
Absolutely. So the reason we chose Sirocco was, number 1, I was very familiar with the tool. And number 2, it's available in lots of different languages, which was meant that you didn't have to be translating. Also, with the visual imagery that you get with the Sirocco tool, it's very easy to understand at a glance, which is really important when you're working with a lot of different stakeholders. So, mind you, if we had the 9 pillars, we might have used the 9 pillars, but we used Sirocco, and also it means that I have data from now 6, 7 different projects, so we can track what's happening from an integrated care in Ireland point of view. So it's a very useful tool if anyone's thinking about tools.
Fantastic. Thank you. Let's give Rini a strong round of applause. Thank you very much. Yeah, thank you. Our second presenter is Patricia. Fantastic. And so I think let's see if the presentation is there. So is it up, the presentation, please?
Ivana. Okay, so thank you so much for giving the opportunity to present our work from Luxembourg. So today I will be presenting you about our quality monitoring approach for Parkinson's disease. So my name is Patricia Martins, and I'm presenting today on behalf of Dr. Ivana Pacu, that fortunately could not be here today. So Parkinson at Luxembourg is an integrated care model that was first developed in the Netherlands by Professor Basblom, and it was implemented, so came to Luxembourg in 2018. And since 2 years ago, almost 2 years ago, this integrated care network has been officially recognized by the Ministry of Health of Luxembourg. So here on the left, you see the main values of Parkinson at Luxembourg. So we really focus on patient empowerment, improving quality of life, quality of care, having multidisciplinary care teams, and we also focus a lot on personalized care management. ParkinsonNet has different aims, and with this comes also a lot of components that need to be in place to achieve the goals. So we focus a lot on education, so the healthcare professionals that are part of ParkinsonNet International, but also ParkinsonNet Luxembourg, they go through a baseline education and also continuous education. We also focus a lot on patient empowerment, so we train the people with the Parkinson's disease. We provide fact sheets, videos that they can better understand the disease. We also now have a care management team in place, and we try to integrate digital solutions. So with this integrated care network, so the Ministry of Health, they were willing to fund and reimburse this network, but they said, so we fund you, but you need to monitor the quality of care that you deliver. So for this, we took a four-step approach to develop our quality monitoring strategy. So in phase 1, we got 19 domains from the Ministry of Health that we should assess. And in phase 2, we went through these domains, and we worked together with the healthcare professionals, the patient ambassadors, to come up with what is feasible and what makes sense for our network. In phase 3, we identified the data sources and the strategy. So it's not like that we start from the beginning to have a full quality monitoring evaluation, but we need to go by phases. And in phase 4, we do data collection and reporting. So here you have an overview of our quality monitoring framework. So we divided it into 4 main categories. So we collect clinical data, so we focus on mortality, disease severity, hospitalization. We also aim to collect patient-centered perspectives, so we focus on quality of life, symptoms, empowerment, and we don't forget the caregivers. So we are also interested in collecting information from the caregivers. So the other domain is organizational and implementation. So here we are monitoring the training of the healthcare professionals, how digital connected they are, how many consultations, how many patients they onboarded into the network, and how many people are dropping out from patient but also healthcare professional points. And last, we also look into costs. So we take in consideration the implementation cost and also the cost across the care pathways. And in the future, we also want to look into cost effectiveness. So a bit down on the slide, you see also the data sources that we are using. So we can use data from hospitals and also from the electronic health record. We can collect data directly from the patients, the carers, the healthcare professionals. So in the future, we aim to collect data through apps, wearables, so to not really overwhelm too much the patients, but also the healthcare providers. For digital connectedness, we can directly but get data from the National Electronic Health Record. And we also did a survey. And for cost, we can look into the health claims data from Social Security. So the indicators, they can be further split into different levels. So we split into input, output, outcomes, and impact. But unfortunately, for the first year, we don't have access to all of this data. So we could only collect data from 10 aspects. So you can see the ones. And in terms of results, so what we achieved so far, so for the last year and a half, so we have 118 clinical recommendations that have been implemented. We have 55 new healthcare professionals that were trained in 2024 and are now part of the network. So the network is now contains more than 120 healthcare professionals. There are 26 monodisciplinary meetings that took place and 15 interdisciplinary regional meetings. We also did 2 multidisciplinary trainings last year, and we usually invite experts, some international experts that come to provide additional training to our healthcare professionals. In terms of outputs, we officially onboarded 426 patients. And here we estimate that we managed to engage between 10 to 20 of the people with Parkinson's disease. So we don't know exactly how many people there are in Luxembourg with Parkinson's disease, but this is our estimation. So we hope that within this and next year we can increase this coverage. So most of the patients that were officially onboarded, they are in the early stage of the disease. And in terms of outcomes, there were 40 complex cases that were discussed in a multidisciplinary team meeting. And there were no dropouts from the patient side, and 8 healthcare professionals left the network for different reasons. So in terms of strength, so we successfully onboarded patients, and we have still a good engagement from the healthcare professional and satisfaction. We have a strong training model, and we were also able to really motivate the healthcare professionals to use the national EHR. In terms of weakness, we are still lacking IT. So we really need support from IT infrastructure, digital solutions, and there's a lack of data harmonization. In terms of opportunities, there is really a high potential for the integration of digital technology, and we have a good leadership in Luxembourg for integrated care models. So there is a national law that allows the creation of 10 integrated care networks for multiple conditions. And in terms of threats for our quality monitoring, we have incomplete data. So this limits the evidence and on the effectiveness, and overall we also need sustainable funding. So as a conclusion, so it's important to take in consideration the quadruple aims of ParkinsonNet, and it's also very important to take the patient perspective, not just the patient, but also the caregiver perspective into the quality monitoring approach. And yeah, from our side, at least from Luxembourg, we are in an urgent need to have IT, so like digital support by any means. So not just for the quality monitoring, but also for the care teams. They are overwhelmed, so they really need support in the documentation, for example. So last, I would just like to announce that we are organizing in Luxembourg a summer school on digital medical devices. So this is organized between Luxembourg and Spain. So if you are interested in participating, just apply. The deadline is end of the month. And I would like to thank you for your time and your attention.
Very good, Patricia. We've got almost 7 minutes for questions. So our colleague from Hungary. Actually, what I'm going to do is, if you've got a question, you could come down here, because you know I'm going to lose weight if I do this the whole day. So.
Thank you. It's a nice presentation. In the beginning, you presented a combination of different data sources. Did you face any ethical issue, ethical barrier to combine this kind of diversity of data from bureaucratic barriers, or reluctant of families or the doctors to combine this kind of data?
Yes, that's a very good question. So right now we are not combining the data sources, because that's, like you just mentioned, it's very complicated. So we are, for the first year, we just rely on very easy data that we can easily access without any ethical approval, because this should be in public interest. So it's to improve the care. So I don't think we need ethical approval for that, because our, in terms of GDPR, should be under public interest. Yeah, but we see a lot of challenge. So for merging, like here we are talking just about 4 hospitals in Luxembourg. Luxembourg is very small. So if already like merging the data from hospitals, this is already complicated, you know, because then you really need to go with the personal data and map the patients. So here we already face a lot of issues. So what we decided for the next years is that we analyze the data individually and we aggregate it. So we will not map the data, so you know, the individual data of the patient over all the categories or the data sources.
Very good. Let me ask if any, oh, fantastic, thank you for, there you go, your name is
Kathy. Thanks so much for your talk. I really appreciated it. I'm wondering if you could share what PROMs and PREMs that whether you're using them or you plan to use them.
Yes, so in terms of PROMs, we use Parkinson-specific PROMs. So we are planning to use the MDS UPDRS, so the part 1B and 2, and the NMS, so it's non-motor symptom questionnaire. We have the PDQ-39, so this is for quality of life. In terms of PREMs, we have, I think we have designed a survey, so since we don't have digital technology yet, and the care team is already overwhelmed, you know, the routine care, we did not start implementing the PROM. So we are waiting for, so we are co-designing an app for the patients now, and then we will integrate and collect information through this app. Yeah.
Thank you very much. You know, I had a question, I'll give you the mic in a second, but I had a question along those lines because in your title, you say person-centered or patient-centered, so you place that. When I saw the PREMs and PROMs, I thought, fantastic, this is great. But then when I looked at when I saw the slide where you put the outcomes, I would challenge to what extent you are capturing really person-centered outcomes. But you know, it's part of a fascinating project. I think it's very well thought, but it's those little links that perhaps you need more time to get into that, right?
Yes, so like I said, we are co-designing now the app, so hopefully within the next year, I think we will do it through maybe a research project to collect the patient perspective.
Fantastic, very good. Oni, I think you've got a question. Thank you, Catherine.
Yes, thank you very much, and thank you very much for your presentation. I really enjoyed it, thank you. So you talk about complex case discussions, and I was wondering, how was complexity defined?
Yes, so I'm not a clinician, so I will give you my perspective. So complex for me, and from what I hear from the clinical team, is that when they see that the patient, so the full potential is not being achieved, and then they are discussing together how they can improve the condition of the patient. Because, so Luxembourg is very small, so usually they do these complex case discussions during these regional meetings, and they know who is treating the patient. So if one of the therapists or maybe the neurologist or care manager notice that there is some unsolved issues, then they bring this case to to the interdisciplinary discussion, and they together decide what could be done better for the patient, and then of course they discuss with the patient to get their perspective and joint decision.
You've got another question? Another minute? Anybody? Any burning question? No? You've got to, let me...
It seems a very good method to combine the diversity of information. Is it among your plan to disseminate this method to other diseases, step by step, to reveal this kind of complex sources, quality improvement opportunities?
Yes, so like I said, in Luxembourg, there will be 10 integrated care networks. So our integrated care network is the more advanced. So all the learnings let's say we are piloting. And then the idea is really to extrapolate or scale up to the other integrated care networks. And I'm talking about technology. So we are thinking how to integrate technology. So technology, consent, so patient consent, quality monitoring approaches. So everything is being tested or developed for Parkinson, and then we just scale up to the other conditions, yes.
Okay, thank you very much. We need to move to the third presentation, but thank you for presenting this to us. A big round of applause for Patricia. Thank you. So we've got two presenters now. The title is Mixed Methods Evaluation of Social Prescribing Program conducted in Singapore, is SingHealth Community Hospitals using the PRISM framework and PNSAT, which is an acronym I don't know, but so if you want to introduce yourself, guys. Yeah, thank you.
Hi, good morning. Thank you for being here at this early hour. I'm Michelle, and this is Kaylee. We're both from Singapore SingHealth Community Hospital, and we're presenting on the Mixed Methods Evaluation of Social Prescribing Program conducted in SingHealth Community Hospital using the PRISM framework. So I'm excited to share with you an innovative approach that SCH have to integrated care that we have implemented here. And it is our social prescribing program. So the social prescribing represents a very paradigm shift in how we view healthcare delivery in Singapore. It's a holistic approach that connects patients with community resources and to address the social determinants of health. So think of it as building a bridge between the healthcare and the community support. So social prescribings will connect our patients with non-medical sources of support within the community. So it will link the patients to various community assets such as community groups, art activities, and voluntary organization. So the outcome has been quite significant in reducing loneliness and social isolation, improving mental and physical health, decreased healthcare utilization, and enhanced support for our vulnerable and older populations. So in 2019, SingHealth Community Hospital implemented social prescribing as a way to strengthen the patient's transitions back to the community living. So two key initiatives was established: the role of the well-being coordinators and our Singapore Community of Practice in Social Prescribing, SCOM. So SCOM is a collaborative network of healthcare professionals, community leaders, and social prescribers working together to advance social prescribing in Singapore. So it provides a platform for them to have knowledge sharing, community engagement, and intersectoral collaborations. A significant milestone is also our collaboration with the Singapore Land of Authority for Innovative Living Asset Map. It's a portal using geospatial technology. It helps our social prescribers to identify what is the nearest community resources for our patients. So the recent spread and scale up is the collaboration with WHO. SingHealth Community Hospital has been designated as the first WHO collaborating center for social prescribing, and it was announced during the Asia Pacific Population Conference in November 2024. So in collaboration with WHO, SingHealth Community Hospital also developed a comprehensive implementation toolkit for social prescribing. So the toolkit can be used to expand, to help healthcare facilities, community organizations, and policymakers to implement and expand the social prescribing in their local settings. So it's like a guide for them on how to do the SP in their different settings. So at the heart of our social prescribing program is our well-being coordinators. So we affectionately call them our WBCs. These dedicated people, these dedicated professionals actually work directly in our ward. So they provide a crucial support in patient profiling, in conducting inpatient activities, providing emotional support to the patients, reconnecting the patient with their interests, and ensuring follow-up care post-discharge. So our WBCs actually work in a multidisciplinary team. So there's an integration alongside the other healthcare professionals, such as the social workers and other stakeholders. They also contribute to the care plans. So it will be, patient will have a more personalized care plan. There's also service integration to help them integrate, to help patients integrate better with the healthcare services. As you know, the older patients will need more help in getting them to get to the resources that they need. So I'll go through how our patients, their social prescribing journey in our hospital. So there's a trust and building elements to it with the WBCs, and also needs assessments and interest for whatever activities that they are more geared towards. Then we will refer them to the community assets nearest to their home, or we will teach them on how to get to the community resources. And sometimes we will also do follow-up post-discharge. So this is on case-by-case basis, because some patients will need more hand-holding. So our community partners actually found the foundation of this whole social prescribing initiative. So we established collaborations with over 200 active aging centers across Singapore, alongside community organizations, government agencies, and Institute of Higher Learning and healthcare sector enterprises. So this extensive network actually support our patients beyond the hospital wall. For example, the AACs, they are designed to support seniors aged 60 and above, so promoting a social interaction within the community. So patients can just drop in and then do social recreation to connect with other older patients. So we have activities like karaoke, arts and craft, cooking and exercise programs. There's also befriending and buddying services within these AACs. Also, ultimately, it's also a centers we provide information and referral to other care services. So it might seem that some of the centers, they will gear more towards women because they provide activities like cooking and crafts. So the AAC actually took a very proactive approach to this, and then they come up with activities that's geared for men, such as like carpentries or food tours, durian tours. So that was something that when we evaluate the program, that's what we found out. So in conclusion, social prescribing actually demonstrates how integrated care can extend beyond the hospital walls, creating meaningful connection between the healthcare and community resources. So it's not just about treating illness, it's about nurturing well-being in the fullest sense. I will pass my time over to Kaylee to share more about our study.
Thank you, Michelle. Building upon our overview of social prescribing in Singapore, I'll now present our research study. So our research study, our team has adopted a concurrent mixed methods evaluation approach guided by the PRISM framework to examine our program's effectiveness. We have two key objectives. Firstly, to identify facilitators and barriers affecting program participation and implementation. And secondly, assessing impact on participants' health and well-being outcomes. For our methodology, we used various validated scales, mainly the UCLA Loneliness Scale and the WHO 5 Wellbeing Index. So these quantitatively measure changes in social isolation and mental well-being amongst our participants. To complement our quantitative data, we are also conducting in-depth interviews with both program participants and implementers to better understand ground experiences and implementation factors. So this allows us to gather comprehensive insights that will inform future program refinements and potential scaling efforts. Our study is still ongoing, but we have done a prelim analysis, and for this presentation, we will focus on our qualitative interviews conducted with our program implementers, which is what we'll be focusing on today. So our demographics for our patients, as shown, our study involved 100 patients, revealing an interesting generation from Malay, Indian, and other communities. Most of our patient participants have higher education, and most of them have retired and are no longer working. Our control group of 49 participants were matched for demographics such as age, gender, and ethnicity to our social prescribing group. These participants were not enrolled in our social prescribing program. We've also recruited 22 program implementers aged between 21 to 70 years old. They span various roles within Singapore's integrated healthcare system, from well-being coordinators to medical social workers, occupational therapists, and doctors, alongside our staff from our community-based active aging centers. So now, let me share our preliminary findings using the PRISM framework, which has helped us understand social prescribing implementation in our local context. Firstly, from the participants' perspective, our study found that SP effectively addresses social isolation among older adults. As one participant noted, those who probably stay alone, those who are older in age, they need some sort of social safety net. This is particularly relevant in Singapore's rapidly aging society. Secondly, looking at our participants' characteristics, patient engagement significantly increases with strong rapport between patients and our WBCs. One implementer highlighted that building genuine relationships through day-to-day engagement allows social prescribing to occur naturally. For our organizational characteristics, building good organizational health and culture and establishing clear roles for WBCs within our multidisciplinary healthcare team has proven crucial. Their integration into ward meetings has enhanced patient care by providing valuable insights into patients' social needs and facilitates better coordination within the healthcare teams. Regarding our community resources, we've identified key barriers, particularly around restricted boundaries of our AACs that hinder patients from joining activities in the community. Some of these AACs have strict postal code restrictions, which can limit access for patients outside of these boundaries. Other things like transportation accessibility in our urban environment also emerged as a key consideration. These restrictions imposed on the older adults hinder their participation, emphasizing on the need for inclusive designs. And lastly, looking at program sustainability, our implementers emphasize the need for SP to evolve with generational changes. Future generations of seniors may prefer digital activities or contemporary exercise options such as Pilates or yoga, reflecting the changing preferences of Singapore's increasingly tech-savvy aging population. In conclusion, our study highlights several areas for refinement in adapting social prescribing to Singapore's context. Firstly, addressing patient mobility barriers, strengthening cross-sectional partnerships, using more tailored approaches to cater to the interests of our seniors, and lastly, expanding community resource accessibility. The future and sustainability of social prescribing in Singapore requires strong cross-sectional partnerships and tailored intervention programs to meet the needs of our diverse ethnic communities and aging populations. Lastly, I would like to thank our study team, all our healthcare colleagues, and our patients who have made this research possible. Thank you so much for listening. And our study is still ongoing, so we welcome your questions and insights. And if you're interested to know more about our study, feel free to connect with us. Thank you so much for your attention.
Thank you very much, Michelle and Kylie. Very, very interesting. I'm sure we've got many questions. Anybody? I do have a question. Shall I start breaking the ice? Perhaps you mentioned it, I'm now focusing on the evaluation. Perhaps you mentioned it, but I might have missed it. The time frame for the evaluation, is it taking, what, months, years? Because I think you mentioned that it's ongoing, yes. But so how long have you been evaluating? And
so we started last year. So the funding is ending next March. So we hope to wrap it out by the end of this year and write a paper on it.
So and it's a summative evaluation, right? So you're looking at outcomes,
yes.
Final outcomes.
Yeah.
It is very interesting because we had a conversation, I think it was yesterday. I don't know if anybody attended the session on the journal on ICIC, the International Journal on Integrated Care. And Nick Goodwin was talking about the need for impact and collecting and getting articles on evaluations of integrated care programs and services. And we were discussing about, impact evaluation. And they were saying, yes, you need like proper evaluations, 2-3 years, summative evaluations. But then sometimes the evaluations are conducted very soon after the program finishes. So they were saying you need to allow, like, let's say, minimum 6 months. So in the end, it's like 3-4 years to conduct an evaluation. That doesn't happen in the things I do at IFIC. And we were saying, first of all, because, for example, data, it's very difficult to get data. Second, you want to involve and co-design, but then the organization has to have some sort of experience in involving service users. And the third thing is the theory of change. And this is my question. Do you have a theory of change? Are you developing a theory of change for this?
So actually, there's since social prescribing is actually quite new to us, it's just started in 2019. So it has been a journey of like adapting the model to how Singapore is, you know. So the first model of how the WBCs and everybody works, right, is actually a bit different from what is going on now. Yeah, so we did take note of like the changes over the months or over the years in our evaluation. Yeah.
And are you, sorry, I'm asking, anybody wants to ask any question? Onya? Question, then you are not allowed to comment.
Well, I think you raise an important question around evaluation and integrated care. I think that we're still stuck in the idea that evaluation consists of 2 types, formative and summative, whereas actually there are over 101 different evaluation theories and more theorists. So there are many, it's a rich tapestry of approaches to evaluation. So you can, and if you consider evaluation as learning in real time, then of course, as we're implementing, we can learn in real time and choose, and you've taken a mixed methods approach, and that's what the evidence tells us is the best approach to take when you're considering implementing complex interventions and complex systems. But it's how frequently you collect that data. So is it possible to collect data in real time? Of course it is. Is it possible to, therefore to make an assessment of how your implementation is going on a very frequent basis? Yes, it is. But then you also have to provide your paymaster with the reports that they require. So really a mixed methods and approach to evaluation, I think, is key to successful evaluation and integrated care.
The discussion was in the context of now you've got the evaluation, even if you are conducting a formative evaluation or a midterm review, for example, or a rapid evaluation, and suddenly is that going to meet the criteria for a scientific publication? Is it going to be accepted in ICIC? It's not going to be accepted in ICIC. So that was the second part of the question. Is like, if you are conducting a midterm review, for example, and you've got like 6 months to do it, you are not going to meet the scientific criteria to then publish the. So that was the.
Then I think the scientific criteria is wrong.
Very good. Questions? Anybody? No, we are going now for the plenary. But I'm going to take like 30 seconds now to say that, guys, this is just for the presenters. You've done great. You've managed your own time. You were sort of given the the task of you've got 20 minutes, and I hope you've enjoyed the experience, taking the feedback that you wanted, and just to reflect on that. When I think you've put the messages that you wanted to, you managed your time as you wished, and I hope you've enjoyed the experience and got what you came for when you came to this conference. So thank you very much, and if we can give them a big applause. Yeah, thank you. Well done. We are a bit slow this morning. I think we need more coffee, everybody. So let's go now to the plenary. Yeah, well done.
you are probably like, thank God, we've made it to day 3. For those of you that were at the dinner last night, I hope you had a nice evening. It was really nice to celebrate our award winners, and we're delighted that we have one of them here with us today, so you'll get to hear Andrew Terrace's presentation. Just to say that, you know, we've been obviously running these conferences for a very long time, but when I first started with IFIC 12 years ago, one of my first conferences was very much centered around integrated healthcare. You know, it was really just looking at the management of older people's care and how we could do it in a more efficient way. Then we introduced a bit of integrated health and social care and so on. But it's really been a journey over the last decade or so. And I think we're at a place now where we're looking to the future where it very much lies with the power of our communities, particularly around our volunteers, our lay people. Ownership of services by communities will absolutely be the centre to their sustainability. So I'm really interested to learn from places all over the world where this is their vision, their mission, this is their ethos, and this is how they do things. Because I think if we don't learn that, we're in big trouble for the future. So I'm delighted to be part of this session. My name is Fiona Lyne, and I'm the Director of Communications at the Foundation. And I'm delighted to be joined by my co-chair and fellow Irish person, Marie O'Brien. Do you want to say a few words?
Thanks, Fiona. I suppose I'm delighted to be here today. I'm working in the National Integrated Care Programme for Chronic Disease in Ireland, working in terms of trying to implement the model. And while we've been focused very much in terms of I suppose trying to align and you know, pivot our services both in the community and in the acute health service, we're very much, I suppose, aware that of the importance of the community-driven and community-based supports that help people to live their lives every day where they are. And I think that's why I'm really delighted to be part of the session today and see how, to learn from other areas and see how that's working, because I think we've done well in terms of our healthcare services, but we need to look now outside of that and see how we can support our populations going forward. So delighted to be here, looking forward to the session, and we might as well just kick off.
So, we are starting off with Tim Altringham, and Tim Altringham is from South Ayrshire Health and Social Care Partnership, and he's actually got 2 presentations, and he's very kindly merged them into one, and he's going to be super efficient so that we have lots of time for questions later. But it's working with communities to design and deliver new models of care, and community planning partners working together to deliver primary prevention and enable people to age well in South Ayrshire. Tim.
No, thank you very much. Great, the slides are up. Bon Dieu. Good morning. South Ayrshire is in Scotland. It is the home of a relatively famous poet by the name of Robert Burns, who most of you will have heard of. It's also the location of 2 championship golf courses, one of which is Troon, which is where the Open in Britain was played last year. Thank you for the opportunity to come and have a conversation with you this morning, and thanks for joining this session. I need to pay tribute to my colleague Billy McLean, who would have been here, but sadly, like our colleague on the stage, he's also injured his Achilles, this time playing rugby, and was unable to travel. So I'm here on his behalf, and he's getting better, but it'll take a wee while. So I'm going to talk a bit about working with communities, and then a bit about our Ageing Well strategy, and the two nest together. Just a little bit about South Ayrshire. As you can see, it's in southwest Scotland. It's got a population of around about 112,000. It's falling relatively slowly. The majority of people live in urban areas of Ayr and Prestwick and Troon, but there is a significant rural population, and that creates issues in terms of service provision. A significant proportion of the population are over 65, 27% or so, and what really kind of creates a pressure for us is a very high dependency ratio. So the numbers of working people are relatively small compared to the number of people needing support. And obviously, it's an area, well, it is an area with little ethnic diversity. The majority of the population are white from the UK, one way or another. The majority of what I'm going to talk about this morning is encapsulated in 2 films. I'm not going to spend much time actually talking about this. Really just to say, in the bottom left, our vision is really critical to us, empowering our communities to start well, live well and age well. And just in terms of that kind of integration agenda, the services for which we're responsible... Oh, sorry, that hasn't gone forward. Apologies. The service for which I and my team are responsible include all of those community services. So we have the reins, if you like, to do that integration across health and care services for children, adults, people with learning disability and mental health, and also those people in contact with the justice system. Our main priorities, if you like, are really focusing on, from this perspective, in terms of this presentation, on primary prevention. You'll see that at the bottom of this triangle. Again, it's a relatively busy slide. But what we're really trying to do is to understand our system as a whole system. What we're trying to do is to do the right thing first time, be person-centered, strength-based and outcome-focused. And one of the areas that we're really keen to invest in and engage with our local communities is in primary prevention. Obviously, a lot of the resources being sucked into service provision for the most vulnerable. But if we don't focus on that engagement, on that primary prevention, the demand is only going to increase further. This is a really busy slide. I'm not going to spend much time talking about this, but what it tries to do is give you that real sense of us working in localities, Troon, Prestwick, and so on. So there's 6 localities. They each have responsibility for developing a local plan with local people, but also looking at starting well, living well, and aging well. And you'll see there, I've mentioned things called the Promise and Children's Plan. So we're looking at across the age band, not just at older people or not just at people, the needs of people with disability. However, sit back and relax. This film, I think, will speak to what we're about much better than I am, and fingers crossed that this works. We spent ages yesterday, the IT guy and I.
Mm-hmm. Hey.
So in South Ayrshire, we're taking a different approach to planning. We're looking at planning at a population level, so involving people right at the start who are either older, so looking at our older population, people with a learning disability, or people with mental health and addictions problems. And also looking at locality planning, so looking down to different places and localities. And through involving people right at the start in generating ideas, and then also holding us to account, so through those champions boards, through to the delivery of services. And we're hoping that through that we can move from a passive engagement of people in consulting them around a strategy through to a participation approach where people are contributing to both what the strategy looks like and also participating in delivering that strategy. But really moving through to a leadership approach where participants, communities and people who use services are delivering and driving and leading on the development and delivery of those strategies. And through that we're hoping to make some big changes in South Ayrshire.
As a planning performance team, we've really changed our perspective on how we engage and communicate with our communities here in South Ayrshire. We know that it's all about relationships and about building that trust and having that co-creation in order to allow us to work together to achieve better outcomes. And we know that ultimately this will empower our communities to start well, live well and age well.
In South Ayrshire, developing the strategy, what's been put in place is a champions board, which we were all encouraged to join after a meeting that BASA held in 2023. And I became the chair of that group. I'm convinced that it's really important that older people have a say in developing an ageing well strategy, because of course they are the people that are going to be ageing well within our community. So we're here to give people a voice. And it's been a very successful operation. We've got, I think it's more than 150 champions that are involved in that. And we hope the strategy will become an action plan and become successful.
So the League of Champions is a group made up with adults with a learning disability, their carers and staff within the social work department to develop the adult with a learning disability strategy, where their voice was the core of the strategy. So they were able to tell us what barriers they faced within the social community, how they were feeling isolated after the COVID-19 pandemic, and what supports we had to offer and put in place to support adults with a learning disability to achieve their best life. So the League of Champions meet once a month, and what we do is we explore avenues within the community in South Ayrshire across the localities to see what opportunities we can provide. So the League of Champions approached myself and the social work team and said that they felt very isolated within South Ayrshire. There wasn't a lot of opportunities in South Ayrshire. So what the League of Champions created was the Community Hub. So the Community Hub is based in the town of Ayr in South Ayrshire, and it's also a drop-in centre as well, where we support adults who are looking for employment but they're unable to work, where we provide them with volunteering opportunities, training to gain employment, but also as well to create a safe space where people can drop in and they can go to groups and they can socialise together. So we're breaking down the barriers of isolation.
I think because of the management structure and the services that are aligned under that management structure, mental health services doesn't sit as it sometimes does in some areas in a silo. I think I'm able to kind of link in and reach out to the locality teams and locality managers and get support for their social work teams, their care at home teams, and kind of get that holistic wraparound care. I think is the biggest thing that we do well in South Ayrshire. In terms of kind of our links with mental health services, I think the other things that's kind of really useful and really invaluable for us is our kind of linkage through the sort of mental health teams themselves. They all sit under the same management structure. They all, and we've started a kind of corporate kind of governance structure that all mental health services attend a governance meeting together. So we're sharing collectively practice. We're looking at where are the transitions between the services and how do we manage those transitions better for the individuals, making sure that we're doing the utmost to kind of care for them at the crucial points in their care and treatment, because those transitions can be quite challenging for people. I think the last thing probably we do is that we do really well is just that kind of talking and listening to people and getting that sort of feedback. I think one of the crucial things for me is that the people that are receiving the service can quite often tell you what needs to change, how it needs to be improved, and I think that is something that we've been really fortunate over the last year, and I've been really fortunate over the last year, they've been able to experience in terms of actually talking to people on a day-to-day basis. And I don't mean just the kind of service users as well, because that's been really valuable, but linking in with our third sector colleagues or voluntary services and making sure that their voice is heard as well, and making sure that their contribution to supporting individuals in South Ayrshire with different health needs is valued and valuable.
We make sure we take a good bit of time to meet with individuals, with families within our communities, to understand what matters to them, in terms of how we support them to manage their own health and well-being, and how we give them the right support and advice to go about that. Some of the things we'll do is we'll have a thing called the Locality Planning Partnership. And the Locality Planning Partnership is a group made up of people from the local area who bring their own lived experience, their community voice, and people who provide services within the local area. And we come together to discuss the priorities within that area and how we can start to support meeting some of those priorities going forward. That will involve a number of different things, where we'll look at data, some of the data from our colleagues in Public Health Scotland. It will tell us things such as life expectancy, long-term conditions, particular conditions or ailments that individuals might have within the local area, and allow us to start to use some of that data to inform how we go forward and provide support. Not only will we hear the lived experience about what matters to people, we'll hear about what works well. So we'll hear about the strengths within the local area, the community supports that people tap into, and it allows us as part of the workforce to think about how we continue to reinforce the community-led supports in the local area, but also actually signpost and support people to tap into those local supports as well. We run participatory budgeting events in our local area. The idea of participatory budgeting events, or PB events as we like to call them, is the idea of investing in our local community. So an opportunity for money to be invested in the local community around the areas that are important to them. How we go about that is we ask community groups to apply for the funding, and then we arrange for a PB event to take place where different community groups will come and talk about the community supports they provide, and local members of the community will come in and vote for a particular group that they'd like to see investment given to. The benefits of this is that it is very much about investing in the local area. It's about investing in community-led supports, and it's about community wealth as well as community investment in health and well-being. The benefits also of that are it's also an opportunity but for members of the public to come in and actually meet some of the community groups that they might not know about. That whilst they may or may not get funding, they can still tap into those supports going forward, and it really helps to bring together that networking that's really important in local areas.
So, to help people age well, we have to be future focused and we have to plan for the future, which we're not very good at doing because we're always whack-a-moling the immediate chaos, aren't we? So today, what we'll be doing is getting people to think about what services we deliver, what new homes do we have to build, how do we allocate budgets effectively, and how do we also support the community and bring them with us when we're doing that. And we're doing that via a serious game, which is a board game, but it helps having something tangible and creative in front of you to think about in an innovative and creative space.
So from my perspective, it's a fantastic opportunity to get everybody in the room and start really thinking about what practically we can do that enables people to thrive into older age and make South Ayrshire a great place to live. So already getting started in the game, really enjoying thinking about what that means for individuals, the impact that housing has, the impact that services have, and the impact that budget decision making has. So it's all of those interdependencies. I think South Ayrshire is a great place where we're already working really well together, but this is really giving us a chance to really think through and rehearse some of those decisions that we make day in, day out. And often if we get those decisions wrong in the real world, obviously big consequences. Equally, if we get them right, that's what we're hoping to do today, run through those and start thinking about what will that mean in real life going forward.
Now, what we've recognised as a partnership is it's not always one size fits all in terms of how we provide support and care to individuals or communities. So what we try and do is we go out to engage with as many villages as possible, appreciating that what a particular person in a particular area might be looking for could be very different to someone else in another village. And it very much is how we work in partnership. As we work going forward, learning together and starting to put supports in place together, very much building on the wellbeing pledge we have in Health and Social Care Partnership of co-production and doing things together.
So one of the challenges we face is that people can be sceptical that their voice will be heard or that it will lead to real change. So really what we want to do is encourage this open dialogue and ongoing two-way communication so that we build trust between us and the communities that we work for. And this really allows us to help to inform better services and to create better plans and strategies which more effectively meet the needs of our citizens.
Okay, that's film one. Oh, you like that? That's good. You'll have noticed my colleague Billy there just towards the end talking about the game that we played. It was a kind of role-playing game. He's extremely competitive and hence the kind of rugby playing. Okay, so I'm going to segue straight into the Ageing Well strategies. A little bit of overlap. Some of the interviews in the next film were in the first one, but I think it's important to kind of give its particular place. What I would say particularly about the Ageing Well strategy is it's nested within something in Scotland called community planning, which has a legislative background to it. It has a statutory basis. I would have to say, although it's a legal construct that requires local government, the police, the NHS, seats of education, further education, higher education establishments, and third sector and so on to meet together productively to plan services, it has a mixed history. And I have to say, certainly from a South Ayrshire perspective, until about 3 or 4 years ago, it was really just a bit of a talking shop that didn't really achieve an awful lot. I think, again, it relies on individuals, their leadership capacity and their strengths and relationships and willingness to build relationships that has allowed us to really motor on from a community planning perspective in South Ayrshire. And one of the big pieces of work that we've done is this Ageing Well strategy. I'm not going to go through that again, This is the strategy. There's a link to it at the bottom of the slide there. Obviously got some coverage in local newspaper for those of you that are from Scotland. That's one of the red tops. And it's proved, I think, a really seminal moment for us as a partnership, really putting us on the map in terms of our direction of travel and so on. And it is truly a sort of co-owned and co-produced strategy. This is still taken from the opening ceremony that took place in the local theatre. This is obviously a community choir sort of singing at it. It was an excellent day. However, sit back and enjoy this. So there's another film of about 10 minutes, and that'll be the end of my presentation. I hope you enjoy this film.
In early 2023, two of our colleagues from the Health and Social Care Partnership, Phil White and Billy McLean, came along to our Community Planning Board, and they spoke about some of the statistics about older people living in South Ayrshire. We know that we have a larger percentage of older people than in the rest of Scotland, and in fact, looking ahead, by 2040, there will be 1 in 4 older people in South Ayrshire. So we launched the development of our strategy at an event in June 2023. It was really well attended, and we wanted to be sure that people knew that we wanted them to walk alongside us in developing this Ageing Well strategy. So we then brought people together again for the consultation, to launch the consultation on our Ageing Well strategy, again in the town hall, and a very energetic event. And we heard from people what were their views on what we'd done so far and what we might want to include in taking actions forward.
So in South Ayrshire, we have one of the oldest populations in Scotland. And for us, it's really important to engage with older people and the wider community in how should we shape care for older people? How should we make arrangements to enable older people to live their best lives as they age?
Ageing well, it's all about respect and understanding what our older citizens need. We are the people we are as a consequence of our parents, our mentors, and the people who shaped us. So I think it's appropriate that we respect those individuals and ensure that we can do what we can to give them the best independent living as they age.
I think it is about being active, being connected, having some sort of purpose, not sitting isolated. Often when people retire, they kind of lose the sense of that. So I'm making plans myself to think about what I do, volunteering, finding out about things, being curious, being up to date, up to speed about what's going on, and that. So thinking of ageing as another stage. So it's not a kind of ending journey. It's much more about another stage and trying to be a bit more kind of hopeful and future orientated, I suppose.
In South Ayrshire, developing the strategy, what's been put in place is a champions board, which we were all encouraged to join after a meeting that VASA held in 2023. And I became the chair of that group. And I'm convinced that it's really important that older people have a say in developing an ageing well strategy, because of course they are the people that are going to be ageing well within our community. So we're here to give people a voice, and it's been a very successful operation. We've got, I think it's more than 150 champions that are involved in that, and we hope the strategy will become an action plan and become successful.
So, to help people age well, we have to be future focused and we have to plan for the future, which we're not very good at doing because we're always whack-a-moling the immediate chaos, aren't we? So today, what we'll be doing is getting people to think about what services we deliver, what new homes do we have to build, how do we allocate budgets effectively, and how do we also support the community and bring them with us when we're doing that. And we're doing that via a serious game, which is a board game, but it helps having something tangible and creative in front of you to think about in an innovative and creative space.
So from my perspective, it's a fantastic opportunity to get everybody in the room and start really thinking about what practically we can do that enables people to thrive into older age and make South Ayrshire a great place to live. So already getting started in the game, really enjoying thinking about what that means for individuals, the impact that housing has, the impact that services have, and the impact that budget decision making has. So it's all of those interdependencies. I think South Ayrshire is a great place where we're already working really well together, but this is really giving us a chance to really think through and rehearse some of those decisions that we make day in, day out. And often if we get those decisions wrong in the real world, obviously big consequences. Equally, if we get them right, that's what we're hoping to do today, run through those and start thinking about what will that mean in real life going forward.
So we all know that being active is really good for you, and there are a plethora of different activities going on across South Ayrshire, something for everyone. So it's about being active, being connected, and being outdoors, weather permitting, of course.
Well, for me, the important part of them coming is the exercise that they get, the benefits to their heart, their lungs and their joints, and seeing those physical changes. But it's a community, it's friendship, it's social. We focus a lot on being able to make friends, sharing kind of common problems that people go through, and that sense of camaraderie. There's nothing nicer than, I think, when someone's struggling with something, you can feel quite isolated. By coming out and meeting other people that maybe are struggling too, it can make you feel like, oh, actually, you know, there's light at the end of the tunnel. I'm around other people that feel the same. So people build a real sense of community around it. And we kind of joke that it's just like a morning out and we just happen to exercise.
It's the variety of movement, and I will say that Lisa, who has recently come as well, is a star. She mixes it up every single week, and she does it so well. And we all love her to bits because she makes us move, no matter what age we are. And as I'm 73, I'm very proud to come along to this class.
I'll be 99 in November. I started early on because I was ill when I was about 5 and I couldn't walk. And I started exercising then. I've just gone on. So I lived in England for many, many years. I came here. I joined the UIR. They had an exercise class. And then the doctor gave me a voucher to come here. Well, just come. Everybody's so nice and it's easy. I mean, you do what exercises you can. I do some and then I've got to sit down because my legs ache. So that's all right. You sit down or you get up, whatever you're able to do.
To one of my groups, I facilitate where we're outside in nature, and after the session where we've been doing lots of outdoor activities, a carer came up to me and said, "You do not know the difference this group is making to the loved ones as well as the people with dementia. My well-being has just risen the minute I arrive at this group, and it stays that way and stays with me so that I can cope better when I get home."
Well, the highlight of my week is meeting up with the fellas on a Tuesday and the ladies. We meet up on the Tuesday and it's great. You're out, you're fresh air, you're meeting people, you're talking to people, and it keeps you fit, you know. It's absolutely wonderful, I love it.
Ageing well, it means getting out and about and meeting people and being healthy and
healthy eating and healthy exercise and out in the fresh air in a place like the community garden or Girvan, because Girvan's got plenty of open spaces. I mean, you don't meet people sitting at home. You've got to come out. So I think ageing well is having things to do.
I can't imagine not doing it, so we'll definitely be doing it for a long time to come, hopefully. I think that it helps. The other thing is it helps us to meet new people as well. So as part of the ageing journey, it will help us to meet new groups of people and to get involved in different things as we move forward.
They come here, they forget their troubles and they meet so many nice people, have a cup of tea or whatever and enjoy themselves.
The old 50s disco is so exciting. It's all the music for the 60s, 70s, 80s and 90s. And it's open to anybody that's over 50. Well, actually, even if you're in your 40s and you like that sort of music, it's ideal to come along. What actually really does amaze me is you see some people coming in and they look quite as if they're struggling to walk, but once they hit that dance floor, they turn into something else. But it's making them alive, it's making them happy, and, you know, sometimes people come on their own, and if they want to, you know, have a date with somebody or a dance with somebody, who knows, but it's about getting people together and enjoying that social interaction with other people. I love it.
You're in a room with other people, which after a lockdown can't really be taken for granted. And yeah, singing has been proven to make you feel good anyway with all your happy hormones. So yeah, I think I sense a community too.
We look forward to it every month, and we meet a lot of people and get to know a lot of people and enjoy the music that Amy plays for us and the games that Pam arranges for us. It keeps our minds active, and we come away feeling very, very happy after our afternoon. I've got no family, I've got no brothers or sisters or anything like that. And my husband and I, we had no children. So whenever I get friends, I hang on to them.
So here we are today. We've now got the draft strategy. We've streamlined all of that information into what we hope is a very readable and engaging strategy. But this is more than a strategy. This is a movement. It's a social movement, so that going forward, anything we do, any services we provide, how we work in the community, we want to make sure that there's an ageing well lens all the time.
Can't have any more of that. We're out of time.
I did have a quick question for you.
All right, okay.
I know we don't have a lot of time, but I mean, it's a great example. There was elements of social prescribing in there. You know, it was great to hear the voices of the older people in the service. So that was a great opportunity because we don't always get to have them here in the room. But I just wondered, you know, in Scotland, you've been on a long journey and you have a lot of these embedded community supported projects. But how resilient are you in terms of financial constraints, changes in leadership? How strong are your services for the long term, and any lessons?
That's not an answer to ask a Director of Health and Social Care and expect a 1-minute answer. There are aspects that are embedded, but I think in common with everywhere else, we are under enormous pressure financially. I think referencing back some of the conversation that there was in the plenary yesterday by, I think it was Alfonso, in terms of the kind of social care aspect of things, I am extremely concerned in a Scottish context about the funding and indeed the apparent status of social care and indeed social work in the system, and I think that issue does need to be addressed. I think we're working hard, as you would see in a South Ayrshire context, to enable people to be as resilient as they possibly can, particularly into older age and people with other disabilities. But there does come a point where people need service. We're rationing it. We're not doing it in a way that many of us would prefer to do, and we're very conscious that we are under pressure to reduce the resource that we put into prevention and early intervention in order to meet the very legitimate needs of those people who have high care needs. But that in itself is something of a vicious circle of decline. So I do think that we need to address that issue, but as I say, particularly in relation to social care. Many of the issues that the NHS is dealing with will not themselves be resolved unless we deal with things in the community. I'll probably leave it. It's probably safest to leave it at that, actually.
Great. Thank you, Tim, and best wishes to Billy. Next up, we have our runner-up Patient and Caregiver Award, which we're absolutely changing the title of next year because we need to mention communities in this award. But it's Andrew Terrace, and he's going to talk to us, I'm going to pronounce it wrong, but Hey Maori o Maiwai, and it's a digital connecting platform. Andrew.
Thanks, Fiona. And today I want to talk less about technology and more about people. So you're not going to see a lot of numbers in this slide or these slides. We'll talk a little bit about what Maiwai is, but first, kia ora, nai mai, haere mai, it's a Māori greeting. I'm Andrew Terrace. I was Program Director for this program. It's been going for a fairly long time, 7.5 years. I've been there for 4.5 years of it, so it's been quite a journey. When I can get the technology to work. I do have some co-presenters today. Sadly, they weren't able to join me on the plane. It's quite a journey from New Zealand, but these are some of them. So I'm just really a channel for some amazing people that we've had on this journey. But first, I want to talk about what's a kete. A kete is Maori for a basket. And I think it's a really good metaphor for our strength of community and how it needs to interlace with our more defined health services. So if you imagine health, social care, police, education, all as single strands that people try and push together and call them integration, it's not very strong. People slip between the gaps. But if you imagine another crossweave of that being community, then that makes it stronger. And I think that's part of the message that I want to talk about today, is that whilst it's quite invisible to people, and a lot of the time it's actually not that well funded, if at all, there's actually a lot of resilience that actually exists out in communities already. And do we really capitalise on that or not? And this journey's been a real lesson for us in that. So where we started from was a relatively simple ask, which was take a 28-year-old computer system that supports community care and replace it. Fairly easy. The reality was somewhat more complex than that. What we had to do is we had to engage more with the NGOs, we had to engage with people and whānau, which is families, and we had to engage with the professionals who were used to delivering care more from the hospital outward. So when we talk about community care, if you imagine sort of outpatient outward from the hospital, that was really the definition of what we were dealing with community care. If you go into the communities themselves and talk about it, there's quite a different picture. So we had to deal with that dynamic and that difference, and we had to somehow mesh the two together. And we had to say, how do we design an information system when everyone is slightly suspicious of information sharing where we were working, and some of them were just not technology savvy or didn't actually see the point of technology. So this is a little bit about our journey. These are the services. We basically had 67 different services all around community. So we were supporting community nursing, diabetes. We were also supporting mental health, both from the community side, but also from inpatient right into prisons as well. And public health, nursing, child health. So we'll focus a little bit more on mental health in this presentation, but this was the scope of what we were delivering. But first, a little bit about context. I want to take you to a place. It's in the far north of New Zealand. So New Zealand's a population, I mean, we're at the end of the earth, frankly. Top of the North Island, next stop Fiji. Bottom of the South Island, next stop Antarctica. So don't bother asking me what the weather's like in New Zealand. But this is the top of the North Island. It's called Northland. It's got around 190,000 population, of which 30,000, or around about 30%, are represented by Māori. So it's actually a very small population, but it's overrepresented in all the wrong ways statistically, despite it being small, or maybe because of it being small and because of it being remote. So when we talk about Māori, which is our indigenous race, many people talk about Māori as a homogenous group. They're not, they're tribal. And what we had to deal with was 9 different tribes who had been fighting for many years. So not only was this a battle with the technology, a battle with classic healthcare delivery from the hospital outward, but equally it was gaining trust, not with just the homogenous Māori, but with individuals that had been at war or at the debating table for years. So that was a little bit about our context. It's also a little bit of a tourism advert, as you can see. Northland is a fantastic place if you can get to it by the roads, which are usually closed through flooding. And the other thing is it's not well supported with technology. There is no real satellite access, etc. there, so they're often knocked out with their technology as well. A little bit first about what's in a name. Why? Why is actually Māori for water. And the symbol there is both the mountains and the sea. And this name was gifted to us, and there was actually quite a lot of thought given to this, because water connects us. Water is about life. Water is about the river that we journey down and the various confluences coming together in that journey. So it was about how do you bring people together through water. The other thing is water exists in different states. So it can be ice, it can be tumultuous, it can be rain, it can be surging, or it can be calm. So again, there was a lot of thought given to the name, and actually a lot of people have gravitated to this name. So it's not just about a health delivery system, it's about wellness and it's about a journey. So we're very proud to have been gifted that name, and we wear the badge with pride. Where did we start? I ran through a list of services earlier on that we were supporting, but one of the services that was already underway, so we didn't invent this, we just came in and supported it with technology, is an amazing group in an initiative called Te Ara Oranga. And how this came about was, I mentioned the stats, or the wrong stats. The methamphetamine use in New Zealand, they monitor it through wastewater. In actual fact, in Northland, many people aren't actually on mains wastewater, so you don't actually have the full stat. But Northland has twice the volume by population, or twice the volume of methamphetamine use in the entire country. And then in the far north, it's double that again. We have a real problem. But what happened was the police and the justice system said, this is not working. We're putting the same people in prison, they're learning to be better cooks, they're training other cooks, and they're coming out and they're doubling the users. And we don't want to take the users, the addicts, and put them in prison either. There must be a better way. So what they did was they invented a club model. They came up with a club funding model between police, social services, education, mental health and addiction. And they said, how do we club together to give people a different trajectory for those who want to actually change their lives? And it has changed a lot of people's lives, and they've actually got a reduction of recidivist rates by around about 30%, which is stunning. So we came in behind that and we said, how do you integrate? How do you talk? And they said, well, we hop in our cars or we hop on the phone and we meet and we try and plan and we write it out on paper, and it's like, that's not very useful. So what we did was we created the system around a multidisciplinary team, multi-agency, multi-organisation, multi-role, and said, how do we actually cluster people around people's journey of care? And the other thing we did is we said it's not about health professionals. In fact, it's not about all of those delivering care. It's about the person's journey and the family that support them, because they're the ones there for the long haul. And we said, so why don't we give access to the system, not just to the professions who are supporting these people at points in time, but on the journey, so the people who are actually part of the care delivery of their family members and the actual addicts themselves have access to the system and define their own journey. quite groundbreaking. But where we started was we had to take stock. We had to look at setting the aspiration, being honest about the starting point. You know, we all say, oh, we deliver good care. No, we don't. Having a look at what the gap is and acknowledging that gap. And I think the other key thing here, and I really commend the team for it, is we had to tell the team and we had to explain, do not go to the table with an answer. Because if people hear and perceive a pre-canned answer, you're not going to build trust. What you need is a compass bearing. You need to be able to say, we're heading in that direction, we don't know how we're going to get there, and to borrow an IHI term, we'll learn our way through it. And this is a wonderful slide put together by a colleague and friend, Karoria Johns, and she basically calls this the evolution. And she said, the aspiration is on the top level, which is whānau, and I come back to whānau being the term of family, family-led care. But the reality is, we're at the other end of it, provider-centric. So this is, how do we get a bunch of providers, and our definition, we may think of integrated care as involving the consumer, but sometimes that's just tokenism of having a consumer in the room. And what this one is it's actually saying, here's a bunch of providers sitting around a table saying, when we deliver care to you, we'll do it this way. We lump it all together and we call it integration. What we're moving towards now is more of a whānau-centric, where it's a two-way conversation. It's centred around the person and the patient, but it's not owned by them. The aspiration really is saying, you as health professionals, us as support people are only there for part of your journey. How do we make sure that people can actually lead their own journey? And that's the aspiration. Where we're currently at is probably somewhere between the first two. So we came up with a metaphor of building a bridge from both sides. We got everyone in a room initially and we started having a discussion, and the power imbalance was huge. We said, this is not going to work, people, because the voice of the clinicians usually drowned out the voice of the actual people and the other people, the NGOs and the people in the room. I hesitate to use the word patients, we hate the word. So the people in the room were sitting there listening, they didn't have a language, there was no common lexicon. So what we said was, let's actually design and build this bridge from two sides at the same time. So again, that was part of our learning on our journey. So on the topic of language, what do we need to move from and to? We needed to move away from patient, consumer, service user terminology, which we hear all the time. We've coined the term person. Go figure. We need to move away from the words case and event and intervention. The fascinating thing about the Māori culture is when you talk to them, they don't talk in terms of their health and well-being or even their children's health and well-being. The mokopuna is the grandchild. What they say is, the course that we set now will not impact my health, may not even impact my child's health, but I want to make sure that by the time my grandchild arrives at this point, that they've got a better life.
Andrew,
all of our measures are deficit-based at the moment. We need to move them into more of a strengths-based measure. And we need to move away from capacity to more of a community and resilience. We've got a massive issue about trust of data as well. Just very quickly, we went originally out to market for a software solution and we used terms like referral, triage, etc. What we found was when we brought people in the room, when we started to use this language, people were looking at us blankly and saying, we don't understand where we fit in this. So we invented a new cycle, which we called Identify, Bridge, Engage, Support. And we asked everyone through their lens and context, where do you fit in this? How do you identify a need? How do you bridge the gap between the need and the support you need to provide? How do you actually engage that person? And once they leave your hands, how do you support them in the future? And what we found was that was a real leveller in the discussion. I'll leave it with some stories, and there's just two stories I want to tell very quickly. I'll reverse these two. So when we went to the IT people and we said we need to enable these new navigators in the system, they said, what's their medical council number? So they phoned one of the people that was a navigator and said, "What's your medical council number?" And she said, "Well, the last time I had a number, I was holding it up on my chest and someone was taking a photo of me, and I don't really want to remember that number very well," because she was actually a navigator who was trusted by her peers because she had been to prison as a drug dealer. And she'd come out the other end, and she'd gone through that program, and she came out and she went through all of the education around social work, and now she supports the people that she used to be. But when you talk to the technology people, they wanted her medical council number. Go figure. The last story I want to leave you with is one about a care package. And this one, I get quite emotional when I talk about this one. So there's a young girl, 13, sexually abused, went through a lot of different foster homes, was completely broken. She got funding for mental health. She went to an NGO, and what the NGO said was, "Leave her with us." And they said, "What do you like?" She said, "I love the ocean." So the owner of this NGO went and found a friend of his, and he said, "If I fund someone to come to you as an apprentice for a boat builder, how would that seem?" I said, "Yeah, that sounds really good." She's now a professional boat builder. She got her mana back. She loves life. That's got nothing to do with a care package. That's a care package. But that didn't come through health. It came through health funding, but it was real care, and it's about wellness. So I just want to leave you with that. Thank you.
Thanks, Andrew. Andrew, before you go, if you were, as you were describing, a lot of this is around building trust across communities and individuals. If you were to give advice on how to approach that building trust, what would it be for other sectors?
Time. I hate to say it. We're an impatient lot. But, you know, I think the speed of integration travels at the speed of trust. And that takes time. You know, there's a saying in Māori about, you know, you sit down, you have 2 cups of tea before you have a real conversation. So it takes about a year before you actually start having a real conversation. But take someone with you who, you know, I'm a middle-class white guy. I'm the last person who should be on the marae talking to these people, but because I'm with people they trust, that opens doors.
Great. Thank you.
Yeah.
Thank you, Andrew. So next up, we have Joanna Schraff from Maastricht University talking to us about a multiple case study on integrated community care approaches in the Netherlands and Belgium. Thanks, Joanna.
Okay, so hi everyone, my name is Joanna Schraft and I'm a PhD student at Maastricht University in the Netherlands. And today I'm going to present the results of my first study, which is a multiple case study on integrated community care approaches. So over the past years, there has been a shift towards organizing integrated care on a neighborhood level, which we also call integrated community care. And many integrated community care approaches have been implemented in the Netherlands and Flanders. However, we currently lack a systematic overview on what they entail and what their similarities and differences are. So we formulated our research question to describe the similarities and differences, and our research question was, how are integrated community care approaches implemented in practice in various contexts in the Netherlands and Flanders? And Flanders is a region in Belgium. And we included integrated community care approaches when they met at least 3 of the 4 inclusion criteria, which were cross-sectoral collaboration, citizen participation, when they had a holistic view on health, and when they had an element of learning and monitoring. And we only included scientific approaches for scientific publications. And this has led to the inclusion of 6 integrated community care approaches. Our data collection consisted of a document study and interviews with people that were involved in the approaches. So you can think of project managers, but also researchers. And we guided our data collection and data analysis on a WHO framework. And the framework presents 5 interdependent strategies to achieve integrated people-centered health services. And we use the framework to do a cross-case analysis and to describe the similarities and differences. So what did we find? So 5 of the 6 approaches were implemented in various regions in the Netherlands, and 1 approach was implemented in various regions in Belgium. And the approaches also differ in terms of their phase. So 1 approach is currently still in the startup phase. 3 have been piloted but then discontinued. 1 was piloted and then further developed, and 1 approach was even scaled up to more than 100 neighborhoods. Most approaches focus on involving all citizens of a neighborhood, but some other approaches also target specific groups of the population. And most approaches focus on improving the overall health and well-being of the population. The involved actors varied across the approaches, so you can think of municipalities, health and welfare organizations. And now I'm going to go through the results based on each of the 5 strategies of the WHO framework. In terms of citizen participation, we found that the practical implementation varied across the cases. So some approaches also used so-called key figures in the neighborhood to implement the approach. And 1 respondent said, "You first start by listening to people, having exploratory conversations. Where do people come together? Why do they meet? And who are the key figures within the community?" And although the practical implementation of citizen participation varied, there was a shared vision that active citizen participation would lead to more suitable, supported, and sustainable approaches. However, some approaches also mentioned that citizen participation requires coordination, financial resources, and time investment. Most approaches seek a balance between flexibility and structure in their governance, and also engage relevant actors in different levels of their governance structure. And 1 respondent describes, these type of challenges can only be solved through co-creation within a network, because these are what you would call wicked problems, complex issues that require not just brainpower and action, but also governance capacity. However, some approaches also describe that they face financial and institutional challenges. So what was commonly described was project-based funding, but also organizational, cultural differences in the organization. All of the approaches that we analyzed take actions to identify the needs in the population, and they do this using different methods. And again, citizen involvement was a common element. And 1 respondent said, "I think the strength of our approach was not to say, this is health and you have to comply with this, but the opposite, asking residents, what does health mean to you and how can we build from there?" Another finding was that some approaches also identify and refer the needs of citizens to appropriate care and support, and where possible, by and within the community. Most approaches also have their shared method or learning approach. Here are some examples, but they still have certain flexibility to adapt their approach to the context. And what was commonly described was the use of connecting figures. So connecting figures are, for instance, process facilitators, researchers, or social workers that basically build the bridge between the community and professionals and organizations. And the value of those connecting figures was also described by a respondent in one of the interviews. And this person described the connecting figures as, these are people, especially when it involves working across different domains, who can understand the different languages and maintain a certain level of independence. Practice-oriented learning and flexible monitoring was commonly used in the approaches. So you can think of participatory action research, but also using learning communities or peer review between different neighborhoods. And in one of the documents that we studied, the value of participatory action was described as it facilitated reflection and learning through a continuous process of dialogue. And since working in a cross-sectoral way as for new competencies for professionals, some approaches also invest in competency development through learning, coaches, but also toolkits that are online available. So in conclusion, we didn't find a one-size-fits-all approach while comparing the different integrated community care approaches. So all the approaches had their own way of working, yet they all had some flexibility to adapt their approach to the context. And based on our study, we cannot state what actually leads to successful integrated community care, but we did find some basic ingredients. So we did find some success factors and challenges that were commonly described. While analyzing the documents, we found that the actual impact of integrated community care was weakly described in the documents. And we also found a lot of publication bias. So lots of approaches were described in a very positive manner in the documents, while during the interviews we also, respondents also reflected on the challenges. So what do we want you to take home from this presentation? So what was very striking is that there are already so many good examples of integrated community care, and there's already so much insight and experience that we can build on. So we don't have to reinvent the wheel every time. And we hope that the basic ingredients that we identified can help you to reflect on your own research and practice. And I would also like to stress the importance of actually truly understanding and taking the time to understand the context and also leave flexibility in an approach to adapt to it. And also be mindful about publication bias. So think, what do you want to communicate? Who's your audience? How do you want to communicate? And how independent are you as a researcher in an integrated community care approach? So thank you very much.
Thank you, Jana. One question. Thank you for sticking to time. You've done a perfect job. So through your research, there's some really good advice from your research, but looking at the projects that weren't so successful, was there any commonalities or trends or one thing in specifically that they did wrong?
Or less well. Oh, less well. So of the 6 approaches, 4 didn't actually make it through the pilot phase. So that was very striking to us. And the 2 challenges that they described were about finance, so the funding of the approach. Those approaches were mostly funded in a project-based manner. So after 3 years, the funding was done, and then they were discontinued. So that was one of the common.
Yeah, it's a common challenge across everywhere. Sustainable financing, always an issue. Any questions from the audience? No, good. Thank you, Joanna.
Okay, thank you.
So next up, we are going to Amarjit Maxwell. And Amarjit, unfortunately, couldn't join us and had fully planned to do so. But she's joining us virtually, so we hopefully have Amarjit with us. And she's going to talk to us about place-based ecosystem for health and well-being supported by a collective impact approach. Amarjit. There she is. Welcome.
Can you hear me okay?
Got you. Loud and clear.
Okay. I will share my screen. 1 second.
Thank you.
Oh, there seems to be two of me on there.
You look like you're sitting out in a beautiful beach somewhere and the waves are crashing behind you. It's very nice. I presume it's a blue screen.
It's wishful thinking. It's wishful thinking. Now, make sure that I've got... can you see what I see? Can you see my screen shared?
Not yet, Amarjit. It's just coming, I imagine.
Okay, 1 second. I'll try again.
Are you sharing?
Oh, that's right. Let's do that. That's better. Okay. Is that working?
No, so the button at the bottom of the screen isn't working for you, the share button. Oh, here it is. Now you go to presentation mode.
Awesome.
There you go, at the bottom of the screen. Yeah. Just a second.
Go.
Yeah, just press it once, it'll be fine.
Presentation mode. Fantastic. Okay.
There you go.
I can see two of
We've
me,
got it.
But that is okay. Kia ora koutou from Aotearoa, New Zealand, and thank you, Fiona, for the introduction. And I want to acknowledge, obviously, the other panellists, because it's been a real gem to listen in to everyone. And obviously, not to be there in person has been a disappointment for me, but obviously the right decision for me right now. So good to see you there, Andrew, as well. It's been a while. Hearing all of the presentations before me, I guess what stood out was that passion for whānau-centred care. And thank you for explaining that, Andrew, because that's a term that I will use in my presentation, being from Aotearoa, New Zealand. But that co-creation in locality settings and the relationship, that stood out for me in terms of listening in on the live stream. So thank you for the opportunity to share some of the work at Think Hauora in relation to community-driven integrated care. Think Hauora is a primary health organisation in the mid-central district, supporting primary and community care. Let me just the next screen. So in the time that I have, I want to share a vision for the future, a vision of integrated care that recognises that we can only succeed through strong relationships, lots of cups of tea, Andrew, trust, a sense of belonging, and of course a shared mission, or as we say in Aotearoa, a shared kaupapa. So I position this presentation by drawing from my time working in local government, in health, and as a community volunteer. I'm influenced by all of these experiences over many years of working, and I'm still learning and reflecting. I'm a passionate Newcastle United fan. As you can see, there's a picture of Alan Shearer there, and there's a piece of my heart that is still in the northeast of England, but Aotearoa is my home. So I want to acknowledge Hope for Health Equity, and specifically our Paiora Healthy Futures Act. Its main aspirations include protecting, promoting and improving the health of all New Zealanders, achieving equity by reducing health disparities, especially for Māori, the Indigenous peoples of Aotearoa, and building towards healthy futures Paiora for all New Zealanders as part of those core components of our legislation that was passed in 2022. So in the current climate of health, it is one that is complex and still undergoing massive change and disruption. And certainly for my organisation, I'm feeling that pretty heavily right now. It will take real collaboration to move us forward. That's for certain. So I'm going to share a vignette, a vision for the future. I will use terms that are indigenous to Aotearoa, New Zealand, and Andrew has explained one of them, and that is whānau, and the family. Another term is rangatahi, and that means young people, and rongoa is traditional Māori medicine. So I'm going to ask you, as you look at the image on the screen, then maybe close your eyes and just sit back and listen as I share this vignette, a story of the future. So imagine a vibrant, welcoming space in the heart of your district where whānau feel a sense of ownership and belonging. A young mother walks into a community hub to receive a health check for her 3-year-old, and she is greeted by familiar faces and the soothing sound of a local musician playing in the background. She joins a workshop led by a Rongoa Māori practitioner, learning traditional healing methods while sharing her experiences with others in her community. In another room, a group of rangatahi collaborate with local artists to create a mural reflecting their aspirations for the future. Healthcare professionals, iwi leaders, and community champions collaborate in shared workspaces, analysing data and co-designing community initiatives. There is a clear set of data and metrics that are tracking and capturing the social return on investment. Trust thrives, voices are heard, and collective action drives meaningful, measurable, positive outcomes to support whānau to flourish. Feedback flows freely, captured through surveys, storytelling, and creative outlets like photography and art. Collaboration moves at the speed of trust, and here that trust is high. The movement of doing with is well understood, and whānau know what they say matters and that they are equals alongside frontline workers, whether it be in primary and community care, local councils, schools, police, or other services. The power of communities is real, and local people are champions for their health and well-being, and they are creating a positive impact. So if you closed your eyes, you can open them now. But that passion for the future and really visualizing that, I think, is what's come out in some of the past presentations as well with patient-centered or whānau-centered care. So that takes me to achieve this desired future. At Think Ora, we've created a business model that supports our vision of connecting communities for well-being. Long-standing vision, long before I took over as Chief Executive of Think Ora, that vision was well embedded, and I believe it, will take us into the future. So our core services, including population health, are captured in this visual. This is a work in progress visual, but it allows us for now to clarify what we do and also to articulate that this is built upon place-based integrated care. Our business model lays the foundation for a stronger path forward, helping us better support improved access to high-quality, equitable health services and drive progress on the key challenges impacting health outcomes. So you'll notice also the term ecosystem, which speaks to the broader health system that our work contributes to and is the concept that will require a strong relational approach as part of a network, and that takes time. Using a foundation of collective impact, this allows us to work across multiple organisations to work in a connected and joined up way. Our founding document, Te Tiriti o Waitangi, underpins the work we do. Many of you will be familiar with the definition of collective impact, and I'm currently researching strengthening collective impact as an enabler for delivering Paiora healthy futures to address inequities in Aotearoa, New Zealand. So there is limited literature in Aotearoa, New Zealand compared to the international studies, and noting, of course, that collective impact isn't new and comes with its critics as well. So part of my research is to critically explore the lessons learned from the various applications of collective impact principles in Aotearoa, New Zealand. And I hope to provide the evidence based on recommendations for the future application of it to reduce those inequities. But as in the business model in the prior reference to the future, collective impact is a way and has been a way of working to bring communities together. An approach that was developed a number of years ago and supported by Collaborative Aotearoa is one that is based on the principles of collective impact and reframed for Aotearoa. So at Think Aora, we are taking that collective impact approach and outcomes-based focus, one that aligns the data and action around a shared vision, or what we call what matters to whānau. Collective impact is an approach to help solve those complex issues within communities and address those inequities that I've mentioned. So applying collective impact in a place-based setting is also interlinked, obviously, with community development, which starts with relationships. There's a common theme coming through: relationships, 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 and focusing on strengthening the social capital through asset-based community development. And I had the privilege of talking with Cormac Russell recently, or a few months ago, gave me some of his time. And his work across the many countries is actually having a great impact. So I see that as a foundation also in our learnings over time as we work with our communities. So taking a place-based care approach allows a focus on service integration that starts with the need. And that came out very strongly from Andrew's presentation, bringing the providers together in a coordinated way, but allowing the whānau to drive that. So if we interweave collective impact, community development as the foundation of place-based care, we can fast forward to the creation of more of an ecosystem, one that looks upon place as a system of collaborators with strong relationships and a network of capacity building. So an integrated care ecosystem is a comprehensive approach to healthcare that involves coordinating those efforts, as I've said, across multiple organisations. So at Think Aora, we are able to create strong networks. For example, we aim to support our general practices using a foundation of place-based integrated care and a network ecosystem. If you think of a forest, that is more than a collection of trees. Beneath the surface, an intricate network of roots and mycelium connects them, enabling communication, resource sharing, and mutual support. So this network actually ensures that the whole ecosystem thrives and that is stronger together, stronger than any tree standing alone. So our network, with its many parts coming together, will allow us to enable all practices to collaborate, share knowledge, access resources. It ensures every practice, large or small, is supported and creating a resilient and sustainable healthcare ecosystem for our communities and benefiting from that collective impact approach. So by ensuring that all practices are connected and supported, we have a healthcare ecosystem that is balanced, adaptable, and strong. At the same time, these well-established practices help support and collaborate with smaller clinics throughout our network, fostering a reciprocal relationship that again strengthens the whole healthcare ecosystem. So when a practice actually faces challenges, whether it be workforce shortages, financial strain, or operational issues, we are there to help, like a hidden root system. So when our ecosystem flourishes, our communities do too. When our network of thriving healthcare ecosystem, ensuring no practice is left behind and every patient has access to care. So this work is actually forming the basis of our operating model at Think Aora and will play an important part in achieving health equity for our district. So we are moving in this space. It's like the business model, work in progress, but we're thinking through on the basis of whānau are at the heart of everything we do within this ecosystem. And thank you for listening. I kept that hopefully short and sweet. I'll leave you with this special proverb from Aotearoa, and I look forward to any questions that you might have, Fiona. But he aha te mea nui o te ao, he tangata, he tangata. What is the most important thing in the world? It is people, it is people, it is people. Kia ora, ngā mihi nui, that's thank you in in Maori. So I'm going to end my
Thanks,
slideshow,
Amjad.
and then I'll be able to see you a bit better.
Great. Amjad, as a leader of many health systems now at this stage, what are some of the lessons for you as a leader in terms of managing expectations and maintaining momentum amongst both the people that you're serving in your community, but also with your colleagues in your workforce? When things are tough, how do you manage expectations and keep the ship sailing?
Oh, that's a big question. I think there are some real phrases that again resonated earlier, and that was, collaboration moves at the speed of trust. So I think building trust is a real lessons learned, and that takes time. So investing in the relationship is a real lessons learned. You can't move too fast. You've got to bring people on the journey with you. But a reflection of late, as you sort of work with urgency to support our communities, there is an element of that momentum that you talk about, of we have to keep pushing ahead and forging ahead. And so often we'll say in Aotearoa, you either on the waka or you're not. And so whilst there's a journey in together, what I sometimes say now more recently is, please don't slow me down, because the only people that are suffering are whānau in the communities, and we have to keep moving at pace to support. But it comes down to communication as well, so as long as you are clear in those lessons learned, sometimes if you move too fast and you're not clear, well, that's on me. So as a leader, it is about communicating and, having that clarity. So clarity of expectations, being very, very clear, it's important. So I'll pause there.
Amjad. Thank you. Thank you, and thank you for spending the time with us today. Round of applause for Amjad. Thank you. So last but not least at all, and I hope you'll bear with us, we'll run slightly into lunch, but not too much. We are joined now by Stephanie Montesanti from the School of Public Health at the University of Alberta, and she will talk to us about the transformation to an integrated patient-centred medical home in primary care led by Indigenous communities. Thank you, Stephanie.
Great, thank you, Fiona. Okay, can everyone hear me okay? Perfect. So I'll briefly introduce myself. You can see my affiliations on the slide. I'm a professor in the School of Public Health and hold a Canada Research Chair in Health System Integration. But really how I describe myself is as a researcher ally. So I have come to this work in relationship and humility and in respect for the community and Indigenous patients and community partners that work closely with me. This work was done in collaboration between my research lab called the CARE Research Lab, which is an applied health policy and systems research program in the School of Public Health at the University of Alberta, and the Indigenous Primary Care and Policy Research Network, which is a 15-year funded network through the Canadian Institutes of Health Research Network Environments for Indigenous Health. And it is a mentorship, training, research program in Indigenous health. And so we engage learners, graduate students, we engage system leaders, Indigenous communities in advancing innovations in health system improvement. So I do want to acknowledge the land in where I live, work, and play. Want to acknowledge the Treaty 6 territory and the city of Edmonton, Alberta. Alberta has become home for me, but I'm originally born and raised in Toronto, Ontario. And so I want to acknowledge the lands and the elders and knowledge keepers who have guided this work, and really grateful for those relationships. A little bit about the Indigenous Primary Healthcare and Policy Research Network. Our vision is a renewed and transformed primary healthcare system that promotes wellness and health equity with Indigenous populations. And that's really important. We've heard a lot about the importance of relationship and working with Indigenous communities in designing innovations that ultimately meet their needs and respect their values and preferences. So we support Indigenous communities, health researchers, and health system partners to engage in research that renews and transforms the primary healthcare system in the province of Alberta. But we do work closely across provinces in Canada to learn from what other provinces are doing and how they're innovating in Indigenous models of care. Our aim is to build capacity for engaging with transdisciplinary research and knowledge sharing. And so transdisciplinarity is really about understanding practice-based knowledge and lived knowledge. So the health system partners that we bring into our work, they're guiding the research questions and the direction. And that's what ensures that the work we're doing is relevant, timely, and necessary. And you can see the three pillars in which we work. So a pillar focused on engagement and reciprocity, another pillar on capacity building, and the third pillar in which I work, which is knowledge mobilization. And the butterfly is our emblem of the network, which is a symbol of transformation. So a bit of background just to situate our work within the network. So Indigenous innovations in care, Indigenous models of care ultimately have emerged as a result of the mainstream healthcare system being unresponsive to the needs of Indigenous peoples. So we're starting to see this growth of Indigenous-centered, Indigenous-led models of care. We heard many of those examples today on this panel that are grounded in strength, wisdom of Indigenous peoples and the traditional and cultural knowledge that is brought to better understanding health and wellness from a holistic perspective. And we've taken the time to learn from these innovations in primary healthcare models across the globe, including our close friends out in Australia who've been doing some work relevant to what I will be sharing today. We've talked, some of the presenters here, one of the threads I noticed is that they all made a connection to a policy or a strategy that has been implemented in their country, and that's an enabler. Much like in our province in Alberta, we're in a similar situation. So we are reforming, restructuring our provincial health system. The work that I'll be talking about, we've been doing this work since 2021, before the restructuring in our province began, but it's a window of opportunity for us right now. So being in close connection and in conversation with health system leaders is timely. So one of the recommendations that's emerged out of what's called the Modernizing Alberta's Primary Care Strategy Initiative included 22 recommendations to support Indigenous primary care delivery or strengthen Indigenous primary care delivery. One of the recommendations from the Indigenous Advisory Panel was to support First Nations, Métis, Inuit across the province to access and connect with a culturally safe medical home and primary care provider. So what is the patient medical home? The patient medical home is a key enabler and foundational unit of integrated care in Canada. By strengthening the patient medical home model, provinces and territories have laid the groundwork for broader integration efforts across health and social care continuum. So in my perspective, the medical home is not just a model of primary care, it is the foundation of a system that aspires to be equitable, coordinated, and responsive. And that integration with community-based resources and services is really important. But I'm going to walk you through the journey of how the patient medical home model has been implemented in the province in Alberta, which has looked differently across provinces in Canada. So I'll be speaking to just our context in Alberta. One thing I wanted to note is the alignment with integrated care principles, how closely the medical home model truly aspires or links to these integrated care principles was something that we critically explored in deconstructing the current patient medical home model in Alberta and what it means for Indigenous patients and communities. So you can, I don't have to, in the interest of time, necessarily run through them, but you can just see what the connection is. So concepts like person-centered care. And these are concepts that we deeply explored in the patient medical home. So what does person-centered or patient-centered care mean for Indigenous patients? How do we move from a physician-led and physician-centered model of primary care delivery to an Indigenous focus or Indigenous-led model of primary care delivery? So this is the framework, as you can see on the slide, of the patient medical home model as it's been implemented in Alberta. Again, note our province is going through a large-scale transformation, and one of the core features is to strengthen the patient medical home model in the province. But the current model as it has been implemented within our primary care networks is what you see here on the screen. So as you can see, resembling the structure of the home here, you have some core foundations and key elements that make up the model. So access to care and information is important. Good things happen when patients can see their own doctor or team, multidisciplinary team, without waiting for care. A focus on culture and a culture of improvement. So those who do the work should be the ones to make decisions about how to improve care delivery. The importance of coordinated care. So the primary care practices being the hub of care in high-performing health services. Strengthening the workforce and engaged leadership is also critical to the patient medical home model, and ensuring that we have the right team to meet the comprehensive care of patients. Primary care networks in Alberta are implemented or located in a range of geographical settings, from urban areas to rural areas. So they are meeting the geographical needs of the populations that they serve to the best that they can. So a lot of this is really dependent on the funding and resource allocations that they receive from the government. One of our starting points was to learn from others and what they've done to advance an Indigenous-centered patient medical home model. So one of the examples, in the interest of time, I think many might be familiar with the NUCA model of care, but I'll just highlight the model in Australia. So we were learning from the POD model that was implemented by the Institute for Urban Indigenous Health. And so they, many years back, piloted an adapted model of care in the Kabulututer Clinic in the North End. And so this POD model refers to a core multidisciplinary team working collaboratively to customize care to meet patient needs. What's really important about the POD model, which is similar to what we see in the NUCA model of care, is that it comprises an administrative coordinator, Aboriginal health worker, RN, GP, working together throughout the patient's care journey. Each of those care providers have equal opportunity and equal say in how primary care services are delivered. So not moving away from this notion or concept of physician-centered to working in a multidisciplinary team, and everyone working to their full scope of practice to meet the patient needs in the best way. What was really key to this adapted model in Queensland, Australia, is that this model was underpinned by their WAYS statement, which is a philosophical and ethical grounding that drives their work. So the WAYS statement is driven by cultural obligation and focusing on the ways in which the team operates to ensure that they do not get lost in Western ways of doing. And in this statement, knowledge is balanced in Western and Indigenous perspectives to ensure that the Institute for Urban Indigenous Health team can work collaboratively and make and recreate knowledge based on their traditional ways. So moving to our journey in Alberta to bring those learnings from other models, our work was grounded in 3 core objectives. 1, to engage in a critical exploration of the patient medical home model as it's been implemented in the province of Alberta. Secondly, to identify opportunities for adapting the patient medical home model for Indigenous primary healthcare delivery. And lastly, to learn from the adapted patient medical home model for Indigenous patients in Australia. And why Australia is that we've actually embarked on a really beautiful collaboration with the team out in Queensland and Australia. So it wasn't a one-time opportunity to come together to learn. It's been an ongoing process of collaboration for us. So as I mentioned, this work began in 2021. At a year into COVID, so we didn't have the opportunity to connect and meet in person, so we began with a virtual dialogue, and that's where our initial thinking was really emerging. So we really just wanted to deeply explore and learn from others, and so we brought knowledge keepers, elders, Indigenous patients, health system leaders, Indigenous primary care providers in the province together to explore the current patient medical home model as it's been implemented in Alberta. We did pre-circulate an evidence brief summarizing a global findings on Indigenous primary healthcare innovations. What are the key characteristics and elements and features of Indigenous-led models of care that could be relevant for us in exploring an Indigenous patient medical home model framework in our province? We did have a graphic illustrator who joined our virtual dialogue, and so the next few slides you'll see the graphic illustrations. This one here was grounded in the question that we asked participants what are the barriers to adapting the patient medical home model for Indigenous primary healthcare delivery. So several barriers were described and brought into conversation in looking more deeply at the current model. One was around the concept of attachment. So what does it mean to be attached to a provider? And why is there so much emphasis on attachment to a physician rather than the multidisciplinary team? But then also thinking about the composition of the multidisciplinary team as well. There was another concern around the lack of an Indigenous primary healthcare focused infrastructure in the province. And so in Alberta, which is very different from primary healthcare organizations that in Australia, is that we actually only have 2 Indigenous focused primary healthcare models in the province, one being in the city of Edmonton and another in the city of Calgary, and that's serving the urban Indigenous population. But when we say that there's minimal infrastructure for Indigenous primary care delivery in Alberta, that's what I'm alluding to. And another barrier was around the disconnect between the patient medical home model as it's been represented in the province and attention to the non-medical determinants of health and what those non-medical determinants of health are for Indigenous peoples. So as I mentioned, our work was really to embark on this process of deconstructing those core concepts that we saw embedded in the Alberta patient medical home model. So what do concepts of attachment, comprehensiveness, accessibility mean for Indigenous patients? And are these the right concepts for an Indigenous medical home? A note around the concept of a home, and that really emerged in our conversations, is what constitutes a home for Indigenous peoples. And this was considered to be an important implementation element. In Western cultures, the idea of a home is something that is solid, stable, stationary. A home exists in a physical space of 4 walls. But from an Indigenous perspective or way of knowing, a home is something that can be reassembled, configured, and positioned by drawing in resources and making connections, strengthening relationships without those permitted infrastructures.
You've 1 minute, Stephanie, just 1 minute.
Participants also outlined several key elements that could be potentially explored within an Indigenous patient medical home, including a focus on relationships and trust, a focus on team-based and relationship-based care, centering on Indigenous values and beliefs, distinction-based care for Indigenous peoples being really important, recognizing the diversity of Indigenous patient populations that are being served, First Nations, Métis, Inuit, that they all have different cultures, histories, and experiences that need to be acknowledged in how we deliver care. Fast forwarding to March of 2023, we held an in-person expert dialogue centered around the same questions. So essentially, we just really wanted to build on the conversation we had in 2021 during our virtual dialogue. And these were the themes that emerged from the dialogue. A theme around relational continuity of care, a theme on how the Indigenous patient medical home model should be partnering with systems, the social and health systems, embracing a holistic approach to healthcare. A third theme around incorporating localized Indigenous perspectives, so this idea that a one-size-fits-all approach doesn't work, and that a medical home model for Indigenous patients would be acknowledging the context and unique experiences of Indigenous peoples within those areas where they live. A fourth theme around how to be adaptable and flexible to fit the local context. And the last theme to explore the workforce and leadership characteristics that are required to develop, implement, and support the daily functioning of an Indigenous patient medical home model. I just wanted to delve into 2 of those themes that I felt were important to note. One was around relational continuity. So you can see here from the quotes that there is really this importance of that relationship and trust that's formed with the team, not necessarily one single provider. And then the other was around incorporating Indigenous perspectives and ways of knowing. So I talked about, on a previous slide, the concept of a home and what a home means for Indigenous peoples. And in Indigenous cultures, the home is something that is sacred. So participants at our dialogue brought forward the concept or analogy of a teepee. The teepee represents a holistic idea of life from birth to death. It is where babies are born, where they progress through life, from children to young adults and to elders. And it is where teaching and ceremony happens. It is where the transfer of knowledge takes place. And I think that's an important grounding for us as we continue to embark on developing this framework for an Indigenous patient medical home model. I know I'm running out of time. This is my last slide, I promise. In terms of what were some of the concerns, again, deeply exploring the current patient medical home model implemented in mainstream primary care. So you can see a number of concerns were noted around availability of resources. There's this idea, and we see this across primary care networks in the province, is that they're not all funded in the same way. And so there are inequities in resource and funding. And so one of participants said, why is it that, you can access care, in one place that's, like going to the Ritz, but then others are, it's like receiving care at a Motel 6, right? And so really acknowledging that there are inequities in how we are funding and resourcing primary care in the province. There was an emphasis around measurement too, in terms of what we measure matters. And really shifting to more strength-based concepts and understandings of health and well-being. You can learn more about our work. So we do have a number of reports from our conversations and dialogues on my Care Lab website. So do not hesitate to get out your phones. The last QR code is if you wanted to learn more about the patient medical home model in Queensland, Australia. So just give people a moment. Okay, and just some takeaways. Establishing an Indigenous patient medical home model in Alberta needs to incorporate Indigenous knowledge, reflect local context and needs, prioritize relational continuity of care, integrate across health and social services. The design of an Indigenous patient medical home prototype can also align with Alberta's evolving health system landscape and the transition to where we're moving, which is a regional primary healthcare networks. And our research team will be using the insights gained from our discussions to conceptualize the key design features and elements of an Indigenous patient medical home model, and working closely with our health system leaders during this window of opportunity that we're presented with right now in the province to support implementation. Thank you.
Wonderful. Thank you so much, Stephanie. And I don't think we have time for questions, so I just want to remind you that we will have the slides available after the conference. It takes us weeks to get them all uploaded, but they will be there eventually. But in the meantime, you can catch up on YouTube all the sessions that were live streamed and recorded here in the small auditorium and main auditorium over the course of the whole conference. So just go to the conference webpage, find the live stream and the YouTube links, and you can watch them there. So just to take the chance, thanks Maria, who didn't have much to do today, and to all our presenters, and to all of you, enjoy your lunch. Thank you.
Well, good afternoon, ladies and gentlemen. We are going to start this afternoon session. The title of this session, just to make sure that you are all in the right session, in the right place, it's home-based and personalized care for all the people. We are going to listen for 4 experiences, actually. We will first go to Iceland, then we will go to Portugal, and then back to Central Europe, to the Netherlands. We are going to have 12 minutes presentation for each of the speakers, then there will be 3 minutes for burning questions. So without further ado, I'm just going to introduce the first speaker. She's Mrs. Berkling Magnusdóttir. She was the second speaker in the program, but we have switched the presentations because I think that it makes much more sense. And the title of her presentation is, "It should be good to grow older in Iceland, integrated health and social care services in the country, in Iceland." So the floor is yours.
Okay. Well, thank you for being here today and for taking the time to listen. I'm quite happy to have the opportunity to share some of the work we're doing in Iceland to improve our service or home-based care, especially for our oldest citizens. In Iceland, we actually believe that growing older should come with dignity, security, and support. And we also believe that by doing that, we have to require strong integration between the social and the health sector. Today, I will be introducing some of the steps we are taking to make this vision to a reality. Good to Grow Older is the name of the Government of Iceland's 4-year action plan. And the plan is to support healthy aging and to improve the quality of life for older people with integration and health in the health and social care. The plan is built up from 5 pillars, and those pillars work together to ensure that older people have access to comprehensive and coordinated services that promote active and healthy aging. I will be here today focusing on the first one, the integration. But just to give you a little bit of Iceland, just a brief overview. We are, of course, this island up in the north, not far away from Greenland, which is very popular those days. And we are only 400,000, or not even 400,000, that lives in this island. And we have 63 municipalities, and we have about 8 health districts. So why integration in Iceland? Well, one of the key challenges we face in Iceland is that the responsibility for these services are still divided in most part. That is, the healthcare is provided by the state, that is, the home nurse, and while the social care is responsible of the municipalities. So this often leads gap in the service, and the state and the municipalities frequently shift responsible back and forth. So too many municipalities tend to define their role in home care very narrowly, and that's both in the terms of what tasks are included and the hour during which services are available. And at the same time, the home nursing services are struggling to retain staff, and in many areas, they are only able to provide lighter care than is needed. At the same time, the expectation of quality and personalized services are increasing in Iceland, while the needs of older people are becoming more complex. So although Iceland is a relatively young country, or nation, not country, but we are a relatively young nation, the 67 plus are 12% of the population. But we are growing, aging rapidly, so in 25 years, this will be 20%. So we really have to act fast, and we believe that one of the key factors is to integrate the home service. We are lucky because we have Reykjavik as a city, the capital city of Reykjavik, and they have been pioneering in this field, offering integrated home service since 2009. And this long-standing experience has provided valuable insight into the benefits of coordinating between health and social care. And one key lesson that we have learned from them is the importance of task shifting. So that is transferring some responsibility from the healthcare professional to social care staff. And this has actually allowed the home nursing team in Reykjavik to focus on more complex care while simpler tasks are managed with social home services staff. So what we have also learned from Reykjavik is that the integration there has fostered innovation, and that's very important. So we have seen a development of new care models, increasing use of all kinds of technology, and a faster response to a changing need. So Reykjavik has also shown us the importance of working together in integrated just from the start. That means as soon as a request for home support is made, both from the people and from the hospital. Those lessons have now informed national strategy for the integrated care throughout Iceland. So that's Reykjavik. Okay. As a part of the Good to Grow Older action plan, 6 pilot projects in integrated home care are currently underway across Iceland. You will hear about one of them later on, but those projects aim to develop new care models that place citizens at the center. And one of the key goals is to reduce the need for nursing home transfer too early. And each of these pilot projects could decide who would run the integrated home care in their area. So that means in some of these pilots, there are the municipality who is responsible for the whole home service, and another, it's the healthcare provider, and sometimes it's the nursing home. So we have actually different types of providers in Iceland. And those pilots will run for 4 years, and we already are 1 year in. At the end of the period, we will evaluate outcomes and identify the most effective outcomes as well as what work best in a different context. So there are lots of, seems it doesn't go. No. Oh, that was all the stars. Sorry, did you see them? Okay, so there's a lot of challenge, and the government is actively working to support municipalities at home, nursing, and scaling up the whole services and improve home care, not only to meet the current demand, but also the future. One challenge must be addressed here. We really need most of the municipalities in Iceland to provide more services overall. And that, of course, costs money. So through the government's action plan, support has been provided in various ways. And I will give you here some examples of that, or actually 4 of them. Well, the first one is that we really had to shift mindset, especially among municipalities and their leaders. And we had to shift the mindset from seeing older adults as burden to recognize them as valuable. And the Good to Grow Older project created a report and a live dashboard. And what we saw from that dashboard is our knowledge that has been very important for us. Those tools show how much people aged 67 and older contribute to the economy as well to the municipality by tax income. So, for example, data shows that older adults currently earn 97% of the national average income, and by 2050, they are expected to make up to 20% of the population, but at the same time contribute nearly 30% of all municipalities' tax income. And those findings have really challenged the myth that older people are mainly a cost and really helped us to shift attitudes, making it much more easier for us to move forward with integrated efforts. So now the municipalities are more willing to invest in helping older people to stay home longer because they can see the benefits. And number 2, a single national application system has been launched through Icelandic official digital government portal. This makes it easier for people all around Iceland to apply for home care. And the process is now the same. So wherever you live in Iceland, you always apply in the same way. And this new application system is also very important because it supports the development of integrated assessment team. We call them MOMA, and this team is made up from the professionals from home nursing, from the social care, and from rehabilitation. So what this team does is they review each application together and decide what kind of support is needed. And this is already, we can see that this leads to more coordinated and better service throughout Iceland. And last but not least, to further support integration and improve home service, the Icelandic government has introduced HUDAS as a national standardized tool to assessing the needs of older adults. And I will tell you about that. So HUDAS is part of the ICF classification. So it's the homeland for them is WHO. So we have been working with the European Office of WHO to see if HUDAS could be our national tool for assessing the needs of older people who apply for home service. And that means both home nursing, social home care, as well as daycare. And the reason we choose HUDAS is because it's not long, it's only 35 questions, and also because people can assess themselves. And that was very important for us, to support person-centered care and keep things simple. So we use HUDAS really as a tool for integrating service in Iceland. It is because HUDAS, it really helps professionals from different sectors collaborate more effectively by providing a shared language and a shared method. And that's the key element in integrated care. So HUDAS is now part of the application process in Iceland official digital government portal and used by our new integrated assessment team all around Iceland. We are already seeing a clear sign that HUDAS is an available tool for implementing integrated home care, and we're looking very forward to gain more information. So who knows, maybe next year we will come to this conference and tell you more about it. Thank you.
Thanks, and thanks for keeping so well the time. Any questions from the audience? No? Oh, yeah, sorry. Up there. Oh.
People can apply for themselves, for home care, but not for home nursing. But mainly it's the hospital and the health sector that also apply.
Any other questions? Perhaps I would like to have a clarification from you. Well, of course, Iceland seems to be a rather small country, in terms of population. So you have been mentioning a national approach and then a number of pilots. Mm-hmm. I was just wondering to what extent there is diversity across these different pilots. So you know that in integrated care, context dependence is also, it's always an issue that we have to be very careful about when deploying new services or running pilots, right? Mm-hmm. So in the case of Iceland, is diversity significant? Is huge, different combination of providers depending on where you are or so on?
Mm-hmm. Well, like I said, it's 6 projects, and it's almost 12 if we divide them in the smaller groups, and you will hear about one of the small groups. So it can be different. Sometimes it is the municipality, but what have happened in this pilot is that the nursing home, they have been a bigger part of this than we expected. So they are actually taking responsible for the integrated home care.
Good. So thanks again. We are still staying in Iceland, so our next 2 presenters, because it will be a joint presentation, are Ms. Cecesla Christine, and I cannot pronounce the surname, sorry for that, and Enrique Wapler, right? Both of them will be discussing the topic about, again, good to grow older in Iceland, how to integrate home care in a small municipality in Northern Ireland, some goals and challenges. So the floor is yours.
Hello everybody, it is a pleasure to be here. We will tell you about our experience to establish integrated home care in Húnaþing Vestra through the development project Good to Grow Older, which Berglind Magnúsdóttir was talking about here before. We are Kristín and Henrike, and I'm administrators of this project. I am a nurse, and I've been working in the healthcare center of the Healthcare Institute of West Iceland in Hvammstanga, and I organized home nursing there over 20 years along with other tasks. Henrik is a social worker for a municipality. She has worked there for 20 years in all areas of social works. Here is an overview what we are going to talk about. Some information about Húnaþing Vestra. Home care was how home care was before we started the project, and the goals and challenges we have to deal with. And then we'll inform you about the current situation.
Yeah, hello everybody. Húnaþing Vestra is a municipality in the northwestern part of Iceland, a rural area with a population about 1,200 people. It has one urban center, Hvammstangi, you can see here, with about 600 inhabitants. And there we have main service like school, kindergarten, nursing home, and grocery store. Other citizens live mainly on farms and work with various farming as well as tourism. Húnaþing Vestra is very sparsely populated, and the distance from Hvammstangi can be up to 70 kilometers. Here you can see Iceland, and on the left, and our municipality and settlements is along the sea and into the valleys, the green area, not at the highland. Húnaþing Vestra is 200 kilometers from the capital area Reykjavik, where we have to go to consult specialists.
Before we start to integrate home care, we worked separate for each other. The home support provided by the municipality offers service about 37 users over the year and receive home support or home delivery food. Together with Henrika, we were 4 employees working in the part-time. Home support was mainly being cleaning, shopping, and chatting with the elderly. Home nursing provided by the healthcare service. Together with me was one particular nurse in part-time. Home nursing means help with, for example, bathing, measurements, medication dosing, and social support. They have been visited twice a week and around 27 users over the year. Húnaþing Vestra will also have a daycare center as a collaboration with the municipality as the nursing home. The authorities allocate 5 places that have been used by 50 elderly people who attend to 1 to 5 days a week. We have served mostly the same group of elderly people through 2 providers, and often been in communication but not in formal cooperation. And we have experienced difficulties to run a service from 2 providers. For example, staff from both systems went to one home on the same day, but on another day no one came. Information did not flow between us. For example, a user suddenly became ill and was admitted to hospital. A lot of driving, which was something unnecessary. Different cost was for service. Home nursing free, but charge for home support. When an advertisement was published for participants in a development project on integrated home care as part of the Good to Grow action plan, we applied and were lucky enough to be selected. Working with the Association of Senior Citizens on a future vision of services, have a lot to say that our application was chosen.
But what are the goals and challenges we integrate for integrated home care? The goal of our project is to provide a holistic and flexible service and add evening and weekend services. Another goal is to offer telehealth and make better use of welfare technology. In addition, we hope that the jobs will be more diverse and interesting, but we also need to use funds in an economical and responsible way because no more funding came with the project. We want to provide the right service at the right time with the right staff, like we have heard here before. And daily challenges can be surprising. Here our staff is trying to catch the parrot from the daycare center. But we have also some challenges. The proportion of elderly people is in Húnaþingi Vestra is 21%, but nationally it is 14% or 12%, like Berglind told you before. A large part of them are between 70 and 80 years old and can be expected to need home care within the next 5 years. The state and local governments work according to different laws and rules that sometimes conflict. It is important to get both users and employees with us in this new approach, which is to keep the elderly active and work with them, but not for them. Because of the distance and weather conditions, like you can see, it is not possible to offer the same service for residents living more than 10 kilometers away from Kvamstangi. This applies mainly to food delivery, upcoming evening and weekend services, and we only can provide daycare service 1 till twice a week for those who live at the countryside. There has not been a common assessment tool, but we needed to find a way to assess the need of each user. Our unit is very small because we have a limited number of employees and have to deal with fluctuations in the number of users. Therefore, the staff must be ready to do the services needed at any given time.
Since January 2025, the integrated home care, which includes home support, home nursing, and daycare, has now earned the Healthcare Institute of West Iceland through a contract with the municipality. All our staff were willing to take a step with us, and more employees have shown interest in the jobs. Since April, we have a new unit at Kvamstangi Nursing Home, where we have an office, interview room, and our staff are access to a cafeteria. There we direct connect with the daycare center as that is at the nursing home as well. The pictures is from the opening, and a very good cake. We have formed an interdisciplinary team, MOMA, to assess the user's needs. It consists of nurse, social worker, physiotherapists, and social connector. And there is the team. We have participated in pilot tests or coordinated screen tools named HUTAS 2. The screen list is self-assessment of skills, well-being, and activity to users. HUTAS, together with Integrated Home Care or COPM, is used to create an individual and holistic care plan. Now we can offer more flexibility and access to more specialist service is easier. The social connector have contacted all 8 years and older and introduced them to service. but listen especially to where the person is risk of social isolation and inform them team to discuss together. Home rehabilitation assess to skills and facilities as the user's home and guide with the rehabilitation. Now we charge for service from one place. The free shelters have been revised, but we are yet to implement them fully. There is good cooperation with the Association of Senior Citizens. They closely monitor the development process and point out which service elements are still missing.
And here are some examples from real practice. The wife of a patient in a nursing home applied for home care for him. He scored rather high with 5 on the Maple Scala from Rai Home Care and 76.1 at Hutas. And now he receives daily home care for ADL, home delivery food, home rehabilitation and daycare twice a week. And also home nursing turns on the washing machine for the resident during the visit, and home support delivers a medication dosing like you can see here on the picture. So both of them saved a special trip. And the social connector informed Christine that an elderly needed a rollator and she applied for the device. It sounds little, but it means a lot. And what is next? We will start to provide evening and weekend services in collaboration with the nursing home in autumn 2025. While staff is on duty at the nursing home, they can go on a home care visit. In such a small community, sometimes there's only one user with needs for home care at the evening and weekend. In the beginning, it is planned that this service will only be in Kvamstangi, but in the future, hopefully, we can also provide it in more rural areas. Until then, and because of the distance, we will introduce telehealth and more welfare technology like screen visits, daily calls, medication dispensers, or telecare system. We do not have yet one registration system to keep track of who is receiving service when. It is our opinion that it's unnecessary for each small unit to create a new system. We hope that the policymakers will create one system for the entire country. Yeah, I think we are done. If you have more questions, then please welcome to ask us or contact us here. And then you're also welcome to visit us in Iceland and Húnaþing Vestra. It is a very beautiful country. Thank you for listening.
Relax now, relax. Don't panic. Thanks, that was good. Actually, it sounds a good lot. You have said it's not much, but it's a good lot, I would say. Any questions from the audience? Yes, over there. Can you speak as high as possible? Because, yeah.
Culturally speaking, is it part of the Icelandic culture to stay in the rules and not bend them? Because you are a very rural, remote area, very far away from leadership, who may not be looking every day at what you're doing. So if you need to get something done, by bending the rules, is that something that you would do and not tell anybody? or you stick by the rules, period?
Yeah.
And I appreciate both sides.
So the question is to what extent Icelanders are willing to bend the rules, right? So. Go ahead.
Okay, I am German, but and we go after the rules, but mostly. But of course, it is for the municipality. We can find our way because the municipality is very strong and it different between the municipalities. But of course, it's different in Hunasing Vestra than in Reykjavik.
You want to add anything? No? Sam? Thank you. Any other questions? No? That's good. Congratulations again. Thanks. So our next speaker is Mr. João Sardo from Portugal, of course, and he's going to talk about designing a national personalized care plan for complex chronic patients in Portugal, a co-creation approach to integrated and patient-centered care. Pues yours, João.
Thank you, Albert. So, first of all, welcome and thank you for being here after lunch and with that amazing sun outside. So, what I bring you today is the results of a co-creation exercise under a European project, but we'll dive more into that in a few minutes. So, to start this presentation, I would love to take you to my hometown. I'm from Aveiro, in the north part of Portugal, and as you can see, a beautiful city with Art Nouveau buildings and canals. And as you can imagine, those canals can create big difficulties on going around the city. So through the years, the city has been growing, and more roads and roundabouts and bridges were created, until the point that the city needed to grow to new places where those canals doesn't exist. So the municipality just did what they normally do. They created without asking no one what was needed to be created. And so, as you can see, this is a new part of my city, and I would ask you to pay attention to this small detail. As you can see in that rectangle, and I will enlarge this picture for you, you can see that we have a new building over there, a zebra to cross the road, and then a beautiful pathway. But the users created a new one, a different one. And you can see in the middle of the grass, they created a new pathway, the one that better serves them. And why am I talking about this? In 2023, Portugal joined a European-funded joint action called ICIC25 that is focused on transferring best practice on primary care. And on that, we choose best practice number 3, integrated care for complex chronic patients from Andalusia. And on that, the tool, there are the personalized care action plans. And with this, mostly then transfer it, we decided to adapt this to the needs of our reality. And we are talking on an elderly population of 10 million with a huge burden of chronic disease. So we changed this a little bit to design a unique individual care plan across all institutions and locations inside Portugal. And I didn't identify myself in the beginning, but I'm from ACSS, the central administration of the Portuguese health system. And to pilot this with us, we have 3 local health units, one from the north of Portugal, from Matosinhos, and 2 from the Lisbon metropolitan area, one São José and the other one Occidental Lisbon. And the question that was bring to us just in the beginning was, what was needed? And three really simple things. Highlight the need for a uniform national response and integrated care, explore the expectations of professionals and users regarding this new service that we are in fact creating and designing, and give voice to the stakeholders. I believe that most of you have accompanied, since the beginning of the year, the launch of the Paris report from OECD, and there they tried to answer to a couple questions. And this is one of the questions that the report tried to answer is, How can healthcare deliver what matters to patients? And to try to give this question a quick response, they created the 3 T's response. And what are those 3 T's? Time, tailored care, and trouble-free and safe care. So that was exactly what we tried to do. Through a co-creation methodology and with 2 groups, one of health professionals and the other one with representatives from patient associations. And I see here on the audience a couple persons that participated on those co-creation groups. And within this, we tried to do a really simple thing. Most of the times, health professionals and patients collect their information through conversation, during consultation, during home visits. And this, you can put everything you want. But sometimes what we collect, or we are able to collect, are these individual pieces that don't necessarily tell a story. And was that what we tried to do differently? We tried to tell their story, we tried to identify their needs, and we tried to create this reality of what they really want and what really matters. So, in here you can find a couple pictures from the activities that we conducted. And now jumping a little bit on results. So, we conduct this activity analyzing 4 areas: empathy, challenges, solutions, and a 4th one called adapt and build responses. Starting on empathy, and here the word may seem a little bit strange, but this is because these are not only expectations, are expectations with the deep knowledge of limits from both sides. And in here we can see that for professionals, the main goals are to identify the regularity of contacts, organization of the scheduling, plan with concrete tasks, and validation with patients and team, and then part of the patients, accessibility, active listening, networking, here very specifically with peer conversations and peer experience exchange, patient and healthcare professional relationship, dedication, trust and availability, and a better follow-up. And what about challenges? What are the challenges that are created by this level of expectations and willingness to receive a new kind of care? So, definition of the case management team was one of the challenges, main challenges identified by professionals. Technological support, here very related with the fact that in Portugal at this moment we still don't have an unique health record system, interoperability of information systems, and balance between bureaucracy and clinical practice. This, once again, a very Portuguese thing, the level of bureaucracy within public services. On the patient side, the need for a case manager who understands the family and social economic context to give some viability to the personalized action plan. Also, social support and personalization of the action plan itself, medication management and therapeutic incompatibilities. And what about solutions? What can we do to make face to these challenges? So, for professionals, the first one is really interesting, a good management of egos. The second one, training on the role of the case manager, definition of the area of influence of those teams, and protocols with community pharmacies. And I will jump to the middle one in the patient side, because you can see the creation of protocols with pharmacies also, and, but other than that, the prescription management and social support, community involvement, and the need for a dedicated and respected case manager. But what this comes to is how can we adapt our very crystallized almost system, but on top of that, that received a couple changes in the last years to build responses. So, professionals identify, for example, the inclusion of social prescription, the non-exclusion of mental health and pediatrics in the group of patients accompanied by these personalized action plans, the involvement of unions and professional orders. On the patient side, the need for a case manager who acts as a mediator and most of all assists them on navigating the system itself, problem-solving ability, adaptation of the action plan to the patient's context, socially and economically, and involvement of family and caregivers. Really jumping in conclusions, the most important piece of information is this ability to compare expectations with the goal to better deliver correct and effective care. And on health professionals' expectations, we can summarize them on greater effectiveness in patient follow-up and engagement, and on the patient's expectation side, a greater satisfaction and sense of security. And with that, I finish my presentation. Thank you very much.
Thanks, Joao. Obrigado. And certainly it's good to see so well timekeeping. Questions from the audience? Anyone wants to ask any question? No? Perhaps I'm just wondering, what are the practical implications? So how do you move from this diagnosis phase that you have done towards reality and practical applications?
Although the part that I've presented is more based on this needs assessment, I will call it, the project has in fact already started, and it's more than half of the project has been passed. And the main goal is to actually implement this. And one of the things that we managed to co-create with both teams was, for example, the digital interface to both of them. And that is already created, and we have a national provider of digital infrastructure, and we are talking with them to, in reality, execute what both professionals and patients co-created as their desired platform to interact with this new service.
That's good. So you are a little bit at the very beginning of your own journey, so to say, right? Any other questions? Otherwise, we will move. Oh, yeah, sorry. Oh. That was good. So the question is, what is meant by egos, by the part of,
Just a really quick disclaimer, that was not said by me personally. I was just moderating and facilitating the sessions, but in reality what I feel that was the feeling behind that was we travel from a very splitted reality between hospital care and primary care since 2023. And in January 2024, we merged both of them under the same board, and this was done national-wise. And you know better than me, most of you are health professionals from clinical professions. So trying to make talk around the same table, hospital professionals, primary care professionals, nurses, doctors, other health professionals, that is hard. It's hard because it's not difficult, it's hard and it's the reality of the word. So I believe that the feeling behind that share of reality from the professionals is exactly that. How can we go around from, oh, I do this for my patient and I do that for my patient? No, the patient is on the system, on the service, and everyone needs to serve the patient to their better ability, but respecting each other and collaborating with each other. And I believe it's more on that.
I agree. We have time for one burden question if needed. No? Good. So let's move to our last two speakers. They are from the, oh yes, sorry. Obrigado, João. They are from the Netherlands this time. So is Marika van der Heijden and Dr. Milo Anjevar. Sorry for that, for damaging your language. So the communication is about better at home, collaboration between general practitioner and elderly care physician. The floor is yours.
Thank you. Well, here's a presentation. Good afternoon, everyone. My name is Marika van der Heijden. I am a PhD student from the Amsterdam UMC Hospital in the Netherlands. And this is my colleague, Milou Ankevaere. She's a postdoc researcher also working at the Amsterdam UMC Hospital. And today we'd like to talk to you about our research, Living Better at Home, the Specialist-Generalist Collaboration. We are witnessing a global increase in the older adults living at home. And these older adults live more years with chronic morbidities. At the same time, we also see an increase in aging in place. Aging in place is the desire and ability for older adults to remain living in their own homes and communities. It is also preferred by the older adults. Aging in place has also several benefits. And one of them is that it improves quality of life. Another one is that it reduces healthcare costs. And it also increases social connectedness, allowing older adults to stay involved in their communities and maintain their relationships. But there are also challenges to aging in place, and that's the accessibility to proper healthcare services. And without proper support systems, aging in place can quickly become unsafe or unsustainable for those older adults with complex needs. To support aging in place, the elderly care physician, or the ECP, is essential, particularly in the Dutch context. The ECP can be seen as the community geriatrician. They are specialized in the care for older adults with complex and often multiple chronic conditions. In the Netherlands, they work in close collaboration with the general practitioner, or GP. And as you can see on the image, the care the ECP provides goes beyond clinical care. It includes building a trusted and personal relationship with the patient, which is key when providing care in the home environment. But in the Netherlands, in the Dutch context, we see different approaches in the working methods of the elderly care physician working in primary care. And that's the reason why we conducted this study. We conducted this study to describe the specific roles and tasks of the elderly care physician working in the primary context and how the collaboration between the GP and the ECP looked like. And to give you a little bit a better idea of what this type of care looks like, I'd like to introduce you to Mrs. Brown. Mrs. Brown is a 77-year-old widower. She's a care avoider and has a lot of distrust. Lately, she complains a lot to the police about her neighbors making a lot of noise, and therefore the police and the neighbors were concerned. The nurse of the general practitioner visited Mrs. Brown, and she wanted to assess her cognition. And she was wondering, does Mrs. Brown have a cognitive impairment? But it was complicated to assess due to her behavioral issues and the care avoidance of Mrs. Brown. And therefore, the general practitioner sent a referral letter to the elderly care physician with the question to assess Mrs. Brown her cognition. The elderly care physician went on a home visit to Mrs. Brown, and she did a comprehensive geriatric assessment, including a cognitive assessment, a discussion of the delusions of Mrs. Brown, and she discussed the difficult relationship with Mrs. Brown and her daughter. Mrs. Brown, her daughter, was also present at the home visit of the ECP. The elderly care physician asked Mrs. Brown and her daughter, "What do you like to achieve with me, my care? What can I provide for you?" And Mrs. Brown said, "I have no goal. Everything is going well." Mrs. Brown, her daughter, said, "I hope that when her condition worsens, I will receive support in finding a suitable and nearby place for my mother. I also hope my mother won't become socially isolated over time." Then the elderly care physician developed a care and treatment plan and discussed this at the second home visit with Mrs. Brown and Mrs. Brown, her daughter. She also discussed the results of the cognitive assessment, and that was Alzheimer's disease diagnosis. She started appropriate dementia care and started a psychotropic drug for the delusions. She also advised Mrs. Brown, her daughter, to go to a psychologist to work on the relationship with her mother. In May 2024, the nurse of the general practitioner contacted the elderly care physician because she saw worsening in delusions. The ECP went on another home visit to evaluate the medication and cognition of Mrs. Brown. In November 2024, she went on another home visit, and in May, she adapted the treatment plan and she started a new psychotropic drug. And in November 2024, she did another reassessment and she saw that the cognition was stable and the delusions were slightly better. In the summer of 2025, there will be a follow-up. This case illustrates the value of the continuous and coordinated care at home. Stabilizing in cognitive decline and managing caregiver expectations are crucial outcomes. For now, I will give the floor to my colleague Milou, and she will tell you more about the methods and the results of our study.
So in order to better understand how the collaboration between the GP and ECP was being implemented and what the benefits and challenges to these collaborations are, we set up the Living Better at Home study. And in this study, we used a mixed methods approach to collect data from the 4 different stakeholders involved directly in the GP-ECP collaboration. So this, of course, are the GP and the ECP themselves and the patient and informal caregivers. We collected quantitative data surrounding patient characteristics, care services provided, and satisfaction. And we collected these prospectively from a total of 99 cases from 5 different organizations across the country. And we also collected similar data retrospectively in another organization across 4 different regions. And next to this, we performed some short interviews and focus group with the different stakeholders involved. So for today, I will focus on the data from the prospective cohort, and Mrs. Brown was one of the cases included in this cohort. On average, the patients in this cohort were 83 years old. More than 2/3 were women. 60% of them lived alone, but almost all of them had an informal caregiver involved. And the medical complexity of the cases is illustrated by the fact that 65% of the patients used 5 or more medications, and they had an average of 3.5 comorbidities at the time. So the care services provided by the ECPs were quite diverse across the different cases, which is also illustrated by the range and duration of involvement of the ECP. So the number of cases in which the ECP was involved for less than 2 months, 2 to 3 months, or 4 months or more was approximately equal in our included cases. So one reason for the diversity in care provided was the diversity in challenges with which the patients presented to the ECP. And this is illustrated by the list of most common categories of ECP treatment goals. Cognitive diagnostics was the most commonly mentioned goal, followed by goals concerning appropriate ADL support and housing, and mental emotional health and behavioral issues. 2 other common goal categories were mobility and fall risk, and a specific focus on caregiver needs and concerns. Despite the diversity in care services, we encountered 4 common themes on the care provided by the ECP. Firstly, the care by the EPC was provided in the home setting, which had several different advantages. This type of care is very accessible and is much easier to accept for care avoiders like Mrs. Brown than a hospital visit, for example. And a home visit also provides extra information to the doctor about the daily reality of a patient's life, ensuring that the treatment plan is also in line with this reality. Additionally, we see that ECPs address the complexity in these cases across different domains and stakeholders. ECPs integrate the needs and goals of the different stakeholders involved in their holistic treatment plan. In Mrs. Brown's case, this was illustrated by the fact that the ECP recognized the negative effects of the difficult relationship between Mrs. Brown and her daughter, and thus suggested psychological support for the daughter. An appropriate communication with the often cognitively impaired patients and their system was another common characteristic of the care provided. ECPs have the expertise and they take the time to effectively communicate with the patients and their support system. And this strength is illustrated by the quote at the bottom of the slide. Mrs. Brown's daughter said, "The ECP is just so warm and friendly. She explains everything so calmly. She took care of everything. She was very involved and took over many tasks." And ECPs do not do the work alone. They attach great importance to working in multidisciplinary teams, ensuring everyone is involved within their own field of expertise. In the case of Mrs. Brown, a nurse accompanied the ECP on the first home visit, allowing the ECP to focus on Mrs. Brown, the physical examination and the cognitive diagnostics, while the nurse spoke with the daughter. So we saw this type of collaboration had a number of different advantages. Overall, the 4 different stakeholders were quite satisfied with the care provided, and all stakeholders groups rated their satisfaction at an average of 8 out of 10. We also saw that the quality of life of patients was stable or improved during the involvement of the ECP, depending on the measure used. Caregiver burden similarly remained stable. And in 73% of the cases, referral to the ECP prevented a referral to the hospital by the GP, which on average would be more costly than the involvement of the ECP. So we have a couple of take-home messages. Collaboration between GP and a community geriatrician enhances quality, continuity, and coordination of care at home. Understanding and aligning goals across patient, caregiver, and professional is key to person-centered care. And involvement of a community geriatrician in a home setting can prevent crises, contribute to quality of life, save costs, and support informal caregivers. So we would really like to thank you all for listening. We would like to thank the rest of the team in the project. And if you would like to ask any questions or learn more about the project, feel free to connect with us on LinkedIn.
Thank you. So, any questions from the audience? Yes, please.
Do you want me to? Yeah, so I think we have to take in, so maybe I can summarize the question. I think the question was that one of the main concerns of the daughter was the impending social isolation of Mrs. Brown. And I think we need to take into account the person, Mrs. Brown here. Mrs. Brown herself was very distrustful and really, I don't think, was looking for social connections. So I think this may be a case of the caregiver and the patient not being on one line. And I know in this case, the caregiver wasn't extremely involved in Mrs. Brown's life. So I think that if this would have been something realistic in which Mrs. Brown also really would have looked for social connectedness, that this would have been something that the ECP or the nurse, more likely the nurse involved, would have also looked into. So how can we support this wish? I don't know if you have anything to add. Did that answer your question? Great.
Good. Any other questions? No? Perhaps just a minor question from my side. Where are you going from here? So next steps?
Well, for now we have the results of our study, and we are describing a generic description so we can implement this type of care maybe in all of the Netherlands, because there are regions where an elderly care physician is not coming to primary care yet. And we also writing, how do you say it? Notes, so they can teach it at schools to learn more about working as an elderly care physician in primary care, or even a specialized nurse working in primary care.
So many thanks. So the session is over now. We still have the last set of parallel breakout sessions of the conference. So just please join whatever is the one of your choice. And just can you just join me with a final applause to all our speakers here? Thank you.